may be more harmful than cold and warm ischemia together. So this is the ischemia. It can lead to ATP depletion, the pump failure, acidosis, membrane damage, and ultimately you have cell swelling, the potassium moving out, the sodium moving in, and you have lysosomal damages. So various methods have been used. There is the cold static storage, there is the hypothermic machine, there is normothermic machine, there is the also the subnormothermic machine perfusion. There are various advantages and disadvantages of all. What we currently practice in India is static cold storage, which of course leads in a reduction in the cellular metabolism like I told you, but it does gradually lead to a gradual depletion of energy and is time limiting. Currently a fair degree of interest in hypothermic machine perfusion, and of course recently a large number of interest in the normothermic machine perfusion. So what are the principles of static cold perfusion? Flush an organ, cool it, and preserve it. That is the basic fundamental of static cold preservations. First used in Collins in 1969, mainstay of preservation. You can keep a kidney in it for as long as 4 or 5 days, wash the kidney with sterile hypothermic solution, get a temperature of -4 and store it in ice. This is what you do. You have a cold flush, you bag the kidney and it goes off to get transplanted. The preservation solution usually is an isotonic or hypertonic is what we currently use. It has ions, it has an impermeant, it has a buffer, and it has other substrates like FRS, colloid, and membrane stabilizers. Currently, the solutions that we use are Collins, we use HTK, University of Wisconsin, and a solution that we were involved with developing in Leeds called the phosphate buffered sucrose. Very good, gives very good results, but unfortunately never made it big. So the principles are, you have hypothermia, you give a specific solution that decreases the intracellular environment, a high osmolality, and you remove the free radicals. So the ideal solution should prevent cell swelling and tissue edema. It should maintain a good pH, provide substrates for generation of ATP, and prevent oxygen-free radical injury. This is what all the basic solutions contain. There's PBS 140, there's Eurocollins, a Collins solution, UW, and what we currently use as HTK. So what are the problems if you use HTK? Of course, our biggest problem is it's expensive. Many of the components that you put into it are not necessary. It has a very high viscosity. It has high potassium. And therefore, when you reperfuse your kidneys, you can sometimes get a transient break and a cardiac problem because of the high potassium it contains. Suspended particles after storage. And glutathione oxidase, that is, it has a half-life of only 3 weeks. However, it continues to remain the gold standard in hypothermic perfusion. The anomalies are it has a low sodium, not effective. This is, of course, HTK. It has a low sodium and a potassium concentration, ineffective impermeant, not effective for long-term preservation, but is good for a flush solution because of its low viscosity. So if you look at all the data that comes out, comparing UW versus HTK, and this is, of course, from Peter Morris's group, which one is better, and they compared for static cold storage, UW versus the HTK, and they said that both UW and HTK have lower rates of DGF, which is delayed graft function, than Eurocollins, and there was no difference in DGF between UW and HTK. This is the Eurotransplant data, which again said that UW and HTK were comparable, but of course Collins solution was not as good. So of course the quality of studies comparing both UW and HTK is low. Varying results from studies may be in the change from procurement practices. For donors with a short cold ischemia time or living donors, there is no major difference between HTK versus UW. And it's very difficult for us to have a large randomized trial comparing HTK with UW. However, the recent change has been the return of hypothermic machine perfusion. And this is a machine, and you can notice how kidneys are being preserved in this. The basic issue why we use a machine is it maintains the vascular bed, it provides nutrients, it removes metabolic products, it administers cytoprotective agents, it increases the availability of oxygen, improves the outcome as reduction of primary non-function in DGF, and use of the expanded criteria for donors. So this is an overview. You can have a hypothermic machine, you can have a mid-thermic, sub-normothermic, or a normothermic machine. This is the machine perfusion. It creates a window of opportunity there, essentially, if you have a marginal donor to assess the graft before transplantation. And this is one of the kidneys we used when I was in England. You can notice when we harvested this kidney, it was blue. As you perfuse the kidney in a machine, it gradually becomes this thing, and you know this kidney is going to work because now it's well perfused in a machine and it's nice and pale. So the machine, if you compare machine perfusion versus static cold perfusion, there are a number of trials available. However, remember, as all of us know in medicine, trials tend to be largely funded by people who make machines. So if you look at the data, this is 8 randomized controlled trials, very good, statistical data, and all of them show that yes, hypothermic machine perfusion will give better results than static cold storage. However, overall transplant centers, they conclude, should consider the use of hypothermic machine perfusion in all kidney transplants on the basis of reduced incidence of DGF, cost saving, and improved graft survival. But a recent article, and this is by Marcelo, who is not here at the moment, and Dori Segev, says that it may actually be a smoking gun, which means though delayed graft function is less in patients who have machine perfusion, overall machine perfusion did not lower death-censored graft survival, and therefore they question the widespread use in all allografts as an ideal approach to organ preservation. So still a bit iffy, but if you have a marginal donor, you're not happy with the kidney you're getting, machine perfusion will may be helpful. But remember, this was a scientific paper. They looked at 78,000 donors, and they said we need to consider local procurement protocols, donor factors, and recipient factors. Briefly, I'll move over to normothermic machine perfusion. It's something that had recently come up. Remember, it will remove the metabolic waste. It will give rise to organ regeneration, supply oxygen and nutrients, organ assessment, organ repair, and prevent, most important, tissue reperfusion injury. So this is the sort of machine we were using a long time ago. This is a normothermic machine. Remember, you will use blood to perfuse this kidney. Very few data is comparing it to static cold storage, and what they do show is that it may be suitable in neurological dead patients. ECD kidneys may be suitable. It may be good, but we need more data to be sure that normothermic perfusion is good for renal transplantation. So we know it's physiological, it supports cellular metabolism, it allows viability assessment, it requires however, it's expensive to maintain, it requires a person attendance, and this is just to compare normothermic versus hypothermic. This is what it looks like. You have a centrifugal blood pump, you have a venous reservoir, you have a heat exchanger, you have a speed controller, and you have a ringer solution with 1 unit of O positive blood which you keep perfusing the kidney with. But really the future may lie in using what is called as normothermic regional perfusion, which is something like an ECMO machine. So what they're trying to say is that once you have a kidney in static cold storage, you could at the retrieval center put it on a normothermic, recondition the graft. You could have a kidney that you have taken out in a donor who is on ECMO, so you have normothermic perfusion. You could have non-static cold storage, which is hypothermic machine perfusion. Again, warm it up before reimplanting. So all that would give you time to recondition the graft before you put it in. So in conclusion, little data to support UW versus HTK. Both seem to be excellent, but definitive high-quality trials are lacking. There is strong evidence that favors the use of machine perfusion in all kidneys to decrease delayed graft function. However, there are some papers contrary to the same. And normothermic perfusion offers some promise in evaluating and rehabilitating discarded donor organs, but indications and events are limited and the cost is high. Thank you very much for your attention.
Excellent presentation, sir. Obviously, there are a lot of variations, like in terms of organ preservation across centers, and there are no clear-cut guidelines available. May I ask, like, what you advise, like, at this point of time, like, what solution to be used, and we don't have like a normothermic or hypothermic machine.
Currently, we would, at the All India Institute, we were using ringer solution, adding some steroids to stabilize the membrane of the lysosomes, and some heparin so that clotting didn't occur. Over the last few years, we then changed to HTK, which was more freely available. And currently, I think most centers in India would use HTK solution for kidneys as well as for liver. However, the problem that I said is that it seems to be just as good as UW. The problem with UW is the cost. So we would currently use HTK for tissue perfusion. I have very limited experience with machine perfusion. They are currently available in India, but the cost is high, and it's difficult to get the hospital to invest when our cadaver program, unlike Gujarat, is still struggling.
If there are any questions from the audience. So we will conclude here.
Thank you so much. Thank you so much, Chairperson. Thank you, Speaker, for finishing it bang on time. We would now like to have the quiz so that everybody can win some prizes. Again, take out your phones, start scanning the barcode which is on the screen. We have Dr. Kapil Sejpal right over here. If you want to win, you can bribe him. He accepts beer coupons, whiskey bottles, and so on and so forth. So, and Dr. Kapil just informed me that he doesn't drink, so you can forward it to me and I will give you the leaks. In the meanwhile, if you look at the schedule, we have a coffee break. So we are not going to be having the coffee break, of course, because we would like to win some prizes and immediately move on to the next session and trying to keep it even a few minutes early so that everybody can get a good amount of time as well. So we've got a good number of people. We are moving to the questions. Can we have the question in 3, 2, 1 on the screen, please? Please click the submit button. Don't forget the first one to vote is, no, none of them have voted right now. Yeah, now 4 out of 29, 17, 21. Okay, so we're just waiting for the number to touch 30 and then we're going to show the answers and the winner, of course.
So maximum responses for option B. Now let's see the answer. It's indeed option B, and the winner is Dr. Ankur Mittal. Congratulations. You can collect your prize from TNS counter at 5 p.m.
I have a question, and this one is for the audience. You don't need to answer like this. Would you like to take one more question? Yes or no? And where is Dr. Ankur Mittal? Can we see him here? Please, anybody sit next to him? वो होता है ना स्कूल में भी, whoever is the topper उसके बाजू में बैठो तो win हो जाते हैं, तो उनके बाजू वाले जरा ध्यान रखें, because we're going to have one more question right in front of you. Dr. Kapil is just getting the question ready. We can see the previous winners also. Dr. Jeswani was the one who had an alert mind even in the morning. He has been calling doctors since 7 a.m. God help us now. All right, can we have the question again? Over to Dr. Kapil.
So here we go.
This is the most difficult one, but guesswork is allowed. Googling is also allowed actually, but you have to be fast. 4G, 5G, then I think you can win.
So option B has the maximum responses and it's the correct answer. Dr. Shri Ganesh sir, congratulations. You are the winner for this question. You can collect your prize from the TNS counter at 5 p.m.
Can we have Shri Ganesh to please identify? Hello sir. Oh. Okay, but Shri Ganesh आपने वो पक्का ना सर, नहीं तो विनर के लिए आपने हाथ ऊपर कर दिया नहीं ना? So I believe Dr. Kapil, where are we going to get the prizes from? TNS stall at 5 p.m. So all the winners are going to be collectively the Nephrology Society stall, the TNS stall, to please be there at 5. But again, we've got a question for all of you. Do you think we should do one more quiz? Yes? But I don't know what the prizes are, okay? So we're just playing blind. Sometimes we go on a blind date, sometimes we play blind like this. And the other times we just play blind poker or teen patti. So everybody can get ready, even our volunteers can try. Try your luck. Everybody, please scan the code. It's not working? Then why don't you go on the site, join at slido.com. Just go on slido.com on your browser. Dr. Kapil, you can talk whenever I'm also talking. You can butt in. I'm not going to mind. I'm not at all senior.
You can open your web browser and go to slido.com. It will just ask you your name and this passcode, which is on the screen, left hand side bottom, 8266520. After entering the code, it will directly show your name on the screen and you can participate. No need to create an account, just add your name and the Slido passcode. I think we have enough members to start with this question. Here we go. We have 10 seconds.
In the meanwhile, I just would like to know if we have our next speaker, Dr. Mohammad Rela, with us. I believe he's on his way up, but okay, he shall be joining in shortly.
So here are the responses. Option B has maximum response, 38%. That is the correct answer. Now let's see the name of the winner. Dr. Sandeep Singhal. Congratulations. You can collect your prize from the TNS counter at 5 p.m. Thank you very much.
Thank you so much. With that, we come to the end of the quiz and we move to the next session. And can I request the chairpersons to please join us? Dr. Vatsala Trivedi, Dr. Sarbeshwar Saharia, Dr. R.K. Yadav, and Dr. Rahul Saxena. Can I also request our speaker, Dr. Mohammad Rela sir, to please join us on the dais? And just a reminder, we're going to be keeping on having these quiz questions right in between. All the winners to please collect your prize from the TNS stall at 5 p.m. today itself.
Morning all. It is my pleasure as well as privilege to introduce Professor Mohammad Rela. I think the audience would not require any thing about him because he's just not an excellent surgeon. He is an institution by himself for the liver surgery. He is known worldwide for his surgery, that too in a pediatric hepatic surgery. Last thing I would say is not only a good surgeon, he is an extremely caring person. Welcome to you, Professor Rela. Please start.
Thank you very much. I want to thank ISOT for giving me this prestigious oration, and especially Dr. Sunil Shroff and Dr. Vivek Is it open? My topic is really on pediatric liver transplantation. Size doesn't matter, really, and why I chose size doesn't matter is because there is a lot of worry about. Pardon? The pen drive is with Dr. Not opening. That will be much slower if you put the pen drive. It's a large file.
Am I audible there? Yeah, better now. Welcome to Professor Rela. In fact, he was earlier at Hyderabad at the beginning when he came back from UK and started his practice at a global hospital in Hyderabad, and subsequently he shifted. But before all that, Doctor, I would just like to say a few words about Dr. R.B.S. Yadav, because many of you sitting here may not know him, because he is the person who first started the transplant program at PGI Chandigarh way back in 1972-73. He came from Australia, where he was undergoing training for transplant, and he came back and joined PGI as a faculty in the Department of General Surgery, and subsequently he started the renal transplant program. He is now what I'm hearing is that there's a separate transplant department at PGI. I think this is the only institute in the whole country where you have a separate department for transplantation, and they will take kidney transplant, liver transplant, pancreatic transplant, and other transplant under the same roof. So this is extremely all due to the effort of Dr. R.B.S. Yadav, and he passed away unfortunately about 4 or 5 years back due to some liver issue. And his wife, Mrs. Krishna Yadav, is a pediatric surgeon, I think still in Delhi. So that is a brief introduction about Dr. Yadav, and again, over to Dr. Rela.
Thank you very much. I'll get on with my talk. The pediatric transplantation results have improved over really the decades, as you can see. This is a publication from Professor Ott, and every 10 years the survival has improved, and now you would expect at least more than 90% survival at 5 years. And I always say that it's pediatric transplant which has been responsible for innovations in liver transplantation itself. Whether it's a reduced liver, split liver, or living donor, everything came from innovations in pediatric liver transplantation. And the first split liver, I just want you to think about the dates. 1989 was the first time the split liver transplantation was attempted, and the first living donor was attempted in 1990. I want you to think about the dates, because I went into transplantation in the year 1991. And it's in 1992 that Professor Tanaka came up with the first series of 20 pediatric living donor liver transplantation. So it's been good to see really the pioneers developing that technique at that time. I went to King's in 1991, a year before that publication, and really been involved in pioneers really in the field of transplantation. Many of you know Roger Williams, who was in charge of the adult program, but a lot of you may not know Professor Alex Mowat. He was the only professor of pediatric hepatology at that time around the world, really. And King's was well known for pediatric hepatology and pediatric liver transplantation. And I have to mention really my mentor, Casey Tan, who died earlier this year. He was a pediatric surgeon who took an interest in pediatric transplantation. A lot of you know that he worked in Singapore for many years, and this was a tribute from King's College Hospital for KC10. I was never trained as a pediatric surgeon. Really working with him and doing on-call for pediatric surgery and neonates is what got me interested in pediatric transplant. And now you know Anil Dhawan and Nigel Heaton. So we were the team at that time. Anil is now in charge, Georgina was in charge before him, and these are the three hepatologists and the 2 surgeons who really developed pediatric transplantation in King's. I just put up this picture. In my younger days, there is another Japanese surgeon who was working with us, and he's now, he worked with us in this field of pediatric liver transplantation, and now he is one of the pioneers in the field. Now he works in Japan running one of the largest programs. I put up his picture because you'll see a lot of the work that is done in the small children and large crafts were associated with it. And I have another colleague who worked with me in the pediatrics subsequently, who was our trainee, who's no more, and there was a tribute paid to him by TTS and Liver Transplant Society as well. He died last year of brain cancer. So I went into King's in 1991. I was a registrar and a senior registrar till 1994, and I was appointed as a consultant in 1994, and then a professor of liver surgery in 2004. And me and Nigel took an interest in really the split liver transplant techniques, and it was very early time in Europe. It did not develop in the United States. Most of these techniques really developed in the continental Europe, and the UK, we took this technique and were transplanting right lobes into adult and left lobes into the children, because we had a large pediatric liver transplant population. But what was difficult at that time was trying to convince the adult transplant surgeons that using a right lobe with a cut surface and potentially small blood vessels with a risk of bile leak was safe to do. And we were, at the bottom you see, we were able to demonstrate that the right lobe grafts have as good a survival as a whole graft. We could demonstrate a 90% patient survival with the right lobe graft, which was not inferior to whole liver transplant. I mean, I know many of you as nephrologists would be very protective of your patients to give them the best organ because you had the opportunity for dialysis, but that was not the case in the pediatric age group. So we had to innovate and transplant them, otherwise they had a very high short-term mortality. And we were able to show even in children that split liver transplantation would have an equivalent survival rather than these children waiting for a whole liver. It's impossible for children to wait, small children to wait for a cadaver size matched organ. That was an impossible situation, and that's why these techniques were developed. Now, even though it was possible to transplant most of the children with a left lateral segment, which is about 25% of a cadaver liver or an adult liver in living donor liver transplantation, having children like this child is 15 days old with really a heart failure as well. A PDA had to be ligated. You can see that that child had a thoracotomy just before the transplant was being performed. And these children had a very high short-term mortality, and if not transplanted, they would be dead within 2 weeks of time. So it's this sort of situation which really led us to innovations of transplanting the very small children. And when you look at this, I told you I became a consultant in 1994 in King's, and when we looked at the neonatal transplant in children under 3 months of age, out of the 10 transplants done, there was a 50% mortality. And this wasn't an acceptable situation. And most of the problem was associated with putting a large liver into a small children and not being able to close the abdomen when you put a large liver. And therefore, really the techniques of further reducing these left lateral segments came about. And this is how it would be. I mean, this is a historic picture I have. I don't have pictures like this because we don't do lateral segment into a small child. This will be a 2-week-old baby. The liver doesn't even sit inside the abdomen. It just gets pushed out by the abdominal pressure. You get an outflow obstruction. You can't do biliary anastomosis. You can't do portal anastomosis. And also you have to close the abdomen with a mesh, which causes huge amount of fluid loss because the liver is also partially obstructed and there is a huge amount of fluid coming through. Fluid balance is a problem. So all of these problems were associated with really the patient loss and the graft loss. And we had to do something for these children who are less than 3 months of age. And a lot of them were less than 1 month of age that we were operating. And in addition to that, really, the portal veins were very small in these children. The hepatic arteries were very small. This is a child with biliary atresia, where you see the portal vein size is almost the same as arterial size. You might think that this is an enlarged picture. The vessel size will be about 2 millimeters and 3 millimeters. And there is also discrepancy in how you can match them, because the distance between a porta-hepatis and the IVC in a child is very small, because the liver sitting in between is very small. Whereas you put an adult liver, the distance is so huge. You can't really connect them up. There were also a lot of technical issues that we needed to overcome, and we were using jump grafts and interposition grafts to overcome. So really, one of the largest, I mean, there's not the largest series, a case series of 6 was the earliest publications in 1999. This publication is now 22 years old, which really changed the outlook for these very small children. We called it monosegment. It wasn't a monosegment technically, it is a hyper-reduced graft, where we were only protecting removing the segment 2 vein and protecting all the structures. And you can see out of 6 children, 5 children survived. And this was a huge improvement, 85% survival versus 50% survival in the early days. And you can see an MRI scan of the plane of transection for these livers. Now, sometimes they're even larger to do a hyperreduction, which is the lateral aspect. You could also do an inferior reduction like that, lateral reduction. It's like sculpting, basically. It's like a carpenter cutting away portions of the liver, which you can safely remove and then fit it into these small children. And this is a child that from India with a monosegment. You can see there has been a lateral reduction, there has been an inferior reduction, and even then you won't be able to close the abdomen. You close these abdomens with meshes or something. And what happens in the next 2 weeks, these livers are relatively hypoperfused, and therefore they will shrink very rapidly. You know that livers regenerate very rapidly when they are small. When they are large also, they can actually shrink very rapidly. And in 2 weeks' time, you'll be able to take them out and close the skin. And this is how really the youngest child ever to have a transplant, not just the liver, kidney or heart, 5 days of age, was transplanted with these techniques, using a cadaver liver with one segment, which was a monosegment, which was 1/8 of an adult liver. And that child, she's 24 years old now, a law graduate, and from Ireland. And I was fortunate to bring her to Chennai because it was important to show, I think it's important even in India, to show that somebody who's transplanted at 5 days of age could be as normal as this. And she came to Chennai, and she was really felicitated by the chief minister of that time. And you can see how well she is. She's on very little immunosuppression. She's never had a CT scan after the transplant. She's never had a liver biopsy after the transplant. And she's refusing to have investigations when she's so well with normal liver function. But then, even these hyper-reduced grafts can be difficult. You see here a child who's 2.8 kilograms. You can see the size of my finger there. And you can't fit in even hyper-reduced grafts. And this is where really, and you can see that the oxygenation of these non-anatomical reductions when you close the abdomen is quite different from if they are actually comfortably fitting in. And that's where really this gentleman came into the picture, where he described an anatomical reduction, which is a little bit more difficult than a non-anatomical reduction. And he was kind enough to make me the senior author because we have been looking at this problem for many years, over the last 20 years, as to how to solve or how to safely transplant these very small children. And he again describes that if you don't do an anatomical reduction, you get a less than 80% survival versus more than 90% survival when you do an anatomical reduction. And I've not been really in agreement in some aspects. We have disagreed, and we have always said, now we have techniques to measure the volume of the liver in living donor before we actually do the operation. In the olden days, we were doing cadaver transplant, we were eyeballing these livers, we were cutting them down. There is no way of understanding which is the right volume to put in. But now with living donor, volumetry done with MRI and CT scans, we can more accurately do these operations. And our feeling is that it doesn't matter. I think still at the end of the day, eyeballing will make a big difference. I moved to India in about 12 years ago to Gleneagles Global Hospital, first to Hyderabad and to Chennai, mainly to Chennai because that's my hometown. And is it replicatable in India is a question that many of you want to know. Okay, you've done that in King's College Hospital. It's London. They can provide with ICU facilities, hepatology facilities. What can you do here is a question. We built a large team. I mean, the liver unit alone has got more than 100 staff actually, with more than 30 consultants and a large number of pediatrics. Initially, I was in global. I moved now to our own institute. And in terms of facilities, it's easy to build. If you've got the funding, you can build the facilities. But can you actually reproduce the outcome is a question. In the last 12 years, I've done 2,300 transplants, liver transplants in India. We probably have one of the largest number of DDLTs done, 500, and we have a very large pediatric program, which is one of the largest in the world. We're probably number 3 in the world. There are only 2 Chinese centers who do more than us in terms of pediatric liver transplant. And this year, till August, we have done 66 transplants, so we are going towards doing 100 pediatric liver transplants this year. We have an association with the government now. As you know, the Tamil Nadu government funds transplant fully, adult as well as pediatrics, and with ICH, we are providing a service for pediatric liver transplant for the government as well. And earlier this year, we celebrated 500 pediatric liver transplantation in Chennai. I'm not counting what is done in Bangalore, Hyderabad anyway. And we had our ministers and the health ministers, and you can see most of these children were transplanted when they were less than 1 year of age. And I think youngest child we have done in Chennai is about 1 month of age. 2 weeks, 3 weeks have not been a common problem because most of the causes for them is congenital hemochromatosis. Congenital hemochromatosis is not a common problem in India for us to do 2-week transplant. This child had a transplant at 1 month of age. Our outcome has been comparable to anywhere in the world, any specialist pediatric transplant centers, with greater than 90% survival for both adults and children. We've been busy through the COVID period. You can see only in the first wave there has been a significant drop in numbers. But now we are doing more than 20, 25 transplants a month. I think this year, there have been months we have done 35 transplants as well. We should do about 300 liver transplants and about 100 pediatric liver transplants. What is interesting was the COVID protocols for infection and everything improved the survival. In the last, since April 2020, we have done 532 transplants to August, and you see the survival figure is 97.3%. So the outcome of transplantation has reduced significantly, and you have to say that infection probably contributes to large proportion of our mortality. And when you look at survival of the very small children, coming to the title, less than 7 kilograms, I always say less than 7 kilograms to more than 7 kilograms, because less than 7 kilogram children will not fit in a full left lateral segment, because the GRWR becomes more than 4 or 5, because the left lateral segment normally weighs around 250 grams, and you can see 1 year survival for less than 7 kilograms is not different from that of children who are more than 7 kilograms. So that confirms that size does not really matter. And can we do academically well? Is there an international recognition? I feel that in India, I've had a huge amount of recognition. I think I've become a president of the International Liver Transplant Society for the work that I've done in India, I think, rather than the work I've done at King's College Hospital. Our research output has also gone up. You can see the COVID time, we were not doing very much. We've had 63 publications in that year, in the COVID time, and a lot of them are a very high impact factor. I think the COVID and liver article that we wrote in Journal of Hepatology is now cited 300 times in 2 years. So our citation, my citation is now more than 15,000 with an H index of 68 now, I think. So academically also, it's been possible in India for me to fulfill my dreams, written a chapter in the Gray's Anatomy. This is going to be the last printed version of Gray's Anatomy, and written a chapter in Bailey and Lau on transplantation as well. We've helped the government develop a liver transplantation. At Stanley's program, we have done 41 transplants with 100% survival, which is unimaginable in the government sector. The government has been very kind to me, offering me a DSC. Can we be really world leaders from India? I believe we can be world leaders from India in your chosen specialty, and now I've gone into really minimally invasive hepatectomy. And on the pediatric side, we probably have I used the COVID time really to train. I never was a minimally invasive surgeon. I never did laparoscopic surgery. On the pediatric side, really, I won't show a video of minimally invasive left lateral segmentectomy. In 1.5 years, we have done 135 robotic donor operations. Most of them were done for children, left lateral segment, and with really very minimal complications for these patients, no mortality, and the recipient outcome have also been extremely good. Even monosegments we have done using the robotic techniques. I think I'll leave there. I think I just want to finish off by showing just 1 minute the potential for India in liver transplantation. I think the Liver Transplant Society in India, the surgeons have come together through LTSI. It's working very well now, and there is now we are collecting the data as well. A registry has been formed, and the number of transplants in India is going up rapidly. And if you look at the world number, the bottom is the United States, the second longest is actually China, and the third is India.
I'm an outsider in two ways. I don't live in India, and I'm not a physician, but I've worked with
so you could say India is doing the third largest number of liver
and maybe
transplantation.
our experience can
But there is a
shed some light
potential,
on India's
if you look
experience.
at per
And it's
million
a particular
population
honor for me
data
to be asked to
and
give
extrapolate
Dr. Trivedi
Indian
Oration.
number, it
I
doesn't
had the
even
opportunity
come.
of meeting Dr.
So if
Trivedi in the
India
hospital
does
in
10
Ahmedabad
per
when I visited
million,
in,
we will do
2017.
5 times more
So I was glad
transplants than the
to
United
meet him then,
States.
and I'm glad to speak in his
So
honor
those
today.
of you who want to do liver
So here's
transplantation, I think the
a
field of
chart
liver
put together by the
transplantation
Global
will give
Observatory
you a
on
huge
Donation and
opportunity for the
Transplantation
next
of
coming
kidneys
years. I
transplanted
think there is a
per million
potential for the
population.
numbers to go up at
And
least 5
this
times,
is
if not
put
10
out
times.
the Global Observatory
Thank you very
together with the Spanish ONT. And in terms of kidneys per million population, for the last couple of years, the United States has led, but traditionally Spain has led their second year. And the blue bars are...
Thank you very much, Dr. Rela. As this is an audition, so there will be no question and answer session.
But we would like to felicitate, sir.
Yeah.
Yes. And I would just like Dr. Vivek Kutte, sir, and Dr. Sunil Shroff, sir, to please join us on the stage. Can I also request the chairpersons to please join in, as Dr. Vivek and Dr. Sunil Shroff are presenting the shawl and the Shrifal. Can we have a big round of applause for sir, please? I would now request all of you to please look into the camera for a photograph. Thank you so much, sir. We are very happy to have you here. Thank you so much. Thank you, chairpersons. Thank you, speakers. Thank you, Dr. Sunil, Dr. Vivek. Thank you. We would like to now move to the next session where we have Dr. Alan with us, joining us virtually. At the same time, I would like to invite our chairpersons. Can I request Dr. Sunil Shroff to please join us on the stage, along with Dr. Georgie Abraham, Dr. Pankaj Shah as well.
Welcome, Professor Alvin Roth. We'll get started in a minute. We'll just do a short introduction of Professor H.L. Trivedi. Dr. Pankaj is here from the Institute of Kidney and Research Diseases. Dr. Pankaj, could you just do an introduction? And may I request our co-chairman, Dr. Georgie Abraham, to join us.
increasingly real.
I am fortunate to be the first student of Dr. H.L. Trivedi. He was a legend in history of Indian nephrology and transplantation. He was a founder of Institute of Kidney Disease and Research Center, Institute of Transplant Sciences, and Gujarat University of Transplant Sciences. Transplantation was a passion for him, and that was Dr. H.L. Trivedi.
Thank you, Dr. Pankaj. I have great pleasure in introducing Professor Alvin Roth, a Nobel laureate. He's an American academic. He's the Craig and Susan McGraw Professor at Stanford University and the Gunn Professor of Economics and Business Administration Emeritus at Harvard, President of the American Economics Association in 2017. In 2012, he won the Nobel Prize for his economic sciences jointly with Lloyd Shapley for the theory of stable allocation and the practice of market design. And this he took forward to look at kidney exchange program, and he devised algorithms for that. So, Sir Alvin Roth, great pleasure to have you here, and we will have a recorded video to be played here. And thank you for joining us from another time zone. I think it's good evening for you. So we'll get started with the lecture. Thank you.
Transplants in India. And of course, I'm an outsider. I'm an outsider in two ways. I don't live in India, and I'm not a physician. But I've worked with kidney transplant professionals in the United States for a long time, and maybe our experience can shed some light on India's experience. And it's a particular honor for me to be asked to give the Dr. Trivedi oration. I had the opportunity of meeting Dr. Trivedi in the hospital in Ahmedabad when I visited in 2017. So I was glad to meet him then, and I'm glad to speak in his honor today. So here's a chart put together by the Global Observatory on Donation and Transplantation of kidneys transplanted per million population. And this is put out to the Global Observatory together with the Spanish ONT. And in terms of kidneys per million population, for the last couple of years, the United States has led, but traditionally Spain has led. They're second here. And the blue bars are deceased donations per million population, and the orange bars are living donations per million population. And what you see is that as we get fewer and fewer transplants, as we go from right to left on the screen and look at countries that do fewer transplants, the orange bars start to predominate. That is, countries that are doing relatively few transplants per million population are doing mostly living donor transplants. But of course, there's another way to look at who's doing lots of transplants, and that's by number of transplants. And big countries there, like the US and Brazil and China and India, are going to do more transplants than small countries. So here's the ordering of number of kidneys transplanted, and India is third after the US and China, ahead of Brazil. But what makes India stand out is that India relies heavily on living donor transplants. So that's something to think about as we talk about how to make transplants more accessible in the near term and in the long term. So in the intermediate term, it's clear that in India, you should be thinking hard about increasing recovery of deceased donor organs. Aside from kidneys and livers, you really need deceased donor organs for just about every other kind of transplant. But that'll take a little while, and it's well worth doing, but I'm not going to talk to you about that today. Instead, I'm going to talk to you about how in the immediate, in the short term, you can get some extra living donation of kidneys and maybe of livers by adopting some of the procedures that are now well tried in the US and in Europe. And those are going to chiefly concern kidney exchange. That's the area in which I know most about. But it also have to do with reducing financial barriers for patients and donors. And here in India, obviously expanding coverage by public hospitals and public health coverage is going to help the many poor patients and donors you have. But even in the United States, we've been making very recent progress on removing financial disincentives for donors. So today in the US, we can start to pay for the out-of-pocket expenses that donors have that we weren't always able to pay for. And that's not just, of course, their medical expenses, but travel and lost wages and maybe childcare while they're going through nephrectomies. And again, India is a somewhat special case because the vast majority of transplants are done in private hospitals, which are more expensive than the public hospitals. So that's something that in India will make sense to think about. And just a couple of weeks ago, I was in Buenos Aires at a big international transplant conference. And this question of how to deal with transplants for poorer people was something that had recently been the subject of that come to the attention of a big variety of transplant organizations. And they'd issued a reaffirmation of organ donation, which said in part that donation should take place daily, routinely, and peacefully around the globe, regardless of age, gender, race, education, or income of donors. So that's an issue that I think we have to think about in India, where there are many poor families and therefore poor donors. And they went on to say that these organizations stand against any form of barriers in access, particularly that related to gender, race, religion, and income. So I focus here on income because that's a problem everywhere, and it's a problem that maybe we can do something about, especially because transplantation is not only the best treatment for kidney failure, it's also the cheapest because dialysis is quite expensive compared to transplantation. Loosely speaking, at least in the US, a year of dialysis costs as much as about a transplant. But after a year of dialysis, you need another year of dialysis. So a lot of money to the medical system can be saved by increasing access to prompt transplantation. Now, one way we've been exploring in the US and in Europe and in Britain and Canada and Australia is kidney exchange. And the idea of kidney exchange is that sometimes you have a patient who has a willing donor who has an incompatible kidney. And of course, there's desensitization. I'll talk more about that. But it makes a lot of sense to transplant compatible kidneys when you can. And here you see we have a picture where there's a simple blood type barrier. Recipient 1 could really use a blood type B kidney, and recipient 2 could use a blood type A kidney. That's not what their intended donors have. But you can see in the picture that if an exchange was possible, each patient could get a compatible kidney. So that's a way of increasing the exchange of kidneys, because of course there are other kinds of incompatibilities than simple blood type incompatibilities. And it's medically simpler to transplant compatible kidneys, but it's logistically complex. So in the US, here's a picture from January 2006, where I'm the man in the yellow coat keeping my hands out of the way. And one half of a two-way kidney exchange is going on here in Cincinnati, Ohio. And Steve Whittle, the man in the tiger skin cap, before the surgeries got well underway, he called up Mike Reese in Toledo, Ohio, nearby, and he said to Mike, we're ready here in Cincinnati. We've anesthetized the patient successfully, and we've made the initial incisions. If you're ready also in Toledo, we'll go ahead. And everyone was ready, and they did the nephrectomy. Here's the kidney, and it's going into the patient here. But what that means is that the two-way exchange involved 4 simultaneous surgeries, 2 nephrectomies, 2 transplants. So 4 surgical teams, 4 operating rooms. That's complicated to arrange. And it was clear to us in 2006 that if we wanted to make kidney exchange a scalable way of increasing transplants in the United States, we'd have to overcome this logistical barrier. And the way we do that in the US is with non-directed donors. Okay? And non-directed donors are donors who don't have a particular patient in mind. And before kidney exchange, we used to, after they were qualified, psychologically and medically, they would be invited to give to someone on the deceased donor waiting list. But once the kidney exchange patient-donor pair pool was established, non-directed donors could be given a more interesting option. They could donate to someone in the kidney exchange pool, to a recipient whose donor would pass it ahead to another recipient whose donor would pass it to someone on the deceased donor waiting list. And so we started to do those chains. And again, in 2007, when you took a picture afterward of the people in the chain, they didn't meet until afterward. The way we do these chains is the donors and the pairs are anonymous to each other until, if they wish to meet, when everyone has completed their surgeries, they can do so. But what you see is there's only 6 people in this chain, and that's because of the logistical difficulties. We were still doing chains simultaneously, so we could arrange 3 pairs to exchange, 3 nephrectomies and 3 donations, but not anymore. But what we realized is that that wasn't so necessary when we had non-directed donors. The reason we do exchanges simultaneously when we're doing conventional exchanges, say between 2 pairs, is supposing we didn't do them simultaneously. So here's pair 1 and pair 2. And supposing on day 1, pair 2 gives a kidney successfully to recipient 1. And now pair 2 doesn't have a kidney anymore. And suppose that it wasn't simultaneous, and that on day 2, for whatever reason, donor 1 fails to or can't give a kidney to recipient 2. Well, pair 2 would really have been harmed because they've given a kidney, but they haven't gotten one. And so, so not only did they have a surgery that didn't help them, but they no longer have a kidney to take part in kidney exchange the next time we run a match. So we don't do that. We run those exchanges simultaneously, as I showed you in the previous picture. But supposing we have a non-directed donor, now it becomes possible to arrange a chain so that each pair gets a kidney before they give one. And that cuts down the cost of a risky broken link if it should happen, because suppose the non-directed donor gives to recipient 1 on day 1, and for whatever reason, the same reason as in this other diagram, donor 1 can't or otherwise fails to give a kidney to recipient 2, well, that's disappointing to pair 2, but they haven't been harmed nearly as much because they still have a kidney. They can take part in next week's kidney exchange. So it turns out when, because these chains could be non-simultaneous, because the risk is lower of a broken link, they can also be long. And some of the chains have been quite long. The very first chain was reported in the New England Journal of Medicine in 2009. Mike Reese is the first author, and there are many co-authors, including economists and computer scientists. And here's what the chain looked like. The top picture is from the New England Journal, and the bottom picture is from People magazine, part of the American press. And what you see is there's 21 people in this picture, right? So there's 10 transplants going on, and there are 11 donors. The last donor is blood type AB. It took a while to find her an acceptable match in the patient donor pool, and she was ready when we did, and another 12 people were added to the chain. So the idea of chains is that you can get a lot of transplants from sparked by a non-directed donation. And they can include some very highly sensitized people. So let's think about why long chains are needed. Okay. The short answer is that in the US and in kidney exchange generally, we see lots of highly sensitized patients. And by that I mean is that their percent reactive antibodies are very high. They have lots of antibodies to human HLA. And so here's a distribution of what we're seeing in American kidney exchange. This is from a little while ago, but what I'm pointing out to you is that it's bimodal. We have a lot of pretty unsensitized patient-donor pairs. They mostly just have blood type incompatibilities. And then we have some very highly sensitized patient-donor pairs, and their problem is not blood type incompatibility, it's tissue type incompatibility. And when we look closer at those people with 95 to 100 PRA, we find that they're really highly sensitized. A lot of them are in the 99 to 100th percentile. That is, it looks like they're never going to get a kidney unless there's a really large pool, and unless we can string them together in long chains. So let's think about the long chains, because more than 60% of transplants in kidney exchange in the US are done through chains. That is, more than half of our transplants come not in simple cycles between 2 and 3 pairs that have to come back to the beginning, but in chains where each pair can get a kidney before they give one. So let's think why that's true. And to think about that, here's a visualization of a piece of the data set that we use to match patients and donors and to form chains and cycles. And in this picture, every circle represents a patient-donor pair, and an arrow goes from one circle to another if the kidney from the donor in the first pair is compatible with the recipient in the second pair. And this particular bit of data has all A patients and A donors, so there are no blood type incompatibilities here, only tissue type incompatibilities. And what you see is only a small subset of patients, marked in blue here, have lots of arrows entering. These are the low sensitized, easy to match pairs. They can easily exchange with each other, but the hard to match pairs are going to have a lot of trouble exchanging with each other. And let's think about that. Supposing each of us represented a hard to match patient donor pair, a pair where they need to look at a lot of kidneys before they can find a compatible one. So the chance that my pair can give your pair a kidney is very low because you're highly sensitized. But in a big room full of highly sensitized patient-donor pairs, the chance that we can give someone a kidney is not so small. And the chance that you can give us back a kidney is very small because we're highly sensitized. but the chance that you can give a kidney to someone else in the big room is not so small. And the chance that they can give a kidney to someone else is not so small. And that's how a chain forms. And that's how highly sensitized pairs in a big pool can get transplanted. So some of these chains are very long. Here's the non-directed donor in this first large chain. As you can see, they got to meet each other afterward. But when he donated, he didn't know to whom he was donating, right? And the pairs didn't know who they were getting kidneys from. I mention this because I know there's a concern in India with the authorization committees and elsewhere that maybe donors are paid. But of course, non-directed donors, when they donate anonymously, are not in a position to be paid because they don't know who they're donating to, and their donors don't know who is getting the non-directed donation. So in the US, excuse me, in the US, about 15 to 20% of our living donor kidney transplants are now done through kidney exchange and the associated non-directed donor. Pause for a minute. So in the US, we now have a significant portion of our living donation done by kidney exchange. So let's turn to the case of India and see what the situation is. And here's a piece of the Transplantation of Human Organs and Tissue Act that deals with kidney exchange in India. And what it says is, well, it doesn't just deal with kidney exchange, but with kidney transplants. And what you see is that when a proposed donor and recipient are not near relatives, the authorization committee can still allow the transplant once it makes sure that there's no commercial transaction. But for kidney exchange, for swap donation, that's not the case. The organs, you can only represent someone as their intended donor in kidney exchange if you're a near relative. So that's a restriction that doesn't exist in regular kidney transplantation in India, but it makes it a little harder to get kidney exchange going. And a separate issue is that there's no allowance here for non-directed donors. And as I pointed out, non-directed donors are quite important in kidney exchange in the United States. Now that's not the end of the story, because really creative physicians in India can still manage to do kidney exchange. So here's a picture from a paper by Dr. Vivek Kute on non-simultaneous kidney exchange cycles, not chains, in a country, India, without non-directed donation. And what he's done is he's assembled these long chains that are non-simultaneous. This particular chain starts on 4th of January 2020, and the last transplant that goes back to the original pair is on the 22nd of January. So over the course of a month, all of these transplants have taken place. And these people are not anonymous to each other. Dr. Kute gets them together and introduces them to the problem, and they all sign on to the idea that they're all in this together. And he has a plan for what to do if a chain breaks, if someone's health, if some donor's health deteriorates, or some recipient's health deteriorates in the course of the month. And so the people who he has waiting are all people who could not, without too much difficulty, could take a deceased donor. So this is a really creative, innovative way to get around the fact that in India you can't have non-directed donor chains. But of course, if India relaxed the restrictions on who can be a paired donor, and if it allowed non-directed donation, then long transplants like this could more easily be arranged as chains. And as I mentioned, if the concern in the Indian law is to prevent commercial transaction, that's no reason to make non-directed donation illegal, because non-directed donors are precisely the people who are not in a position to ask for money from whom they're going to donate to, because they don't know who they're going to donate to. So this non-anonymous cycle is a solution that Dr. Kute is finding for the absence of non-directed donors. But non-directed donors would make his life much easier and would allow more Indian kidney exchange pairs to get transplants. Now, another newer idea, in a certain sense, one that's not yet in big use in the United States, is to start deceased donor chains, to start kidney exchange chains with deceased donor kidneys, right? So right now, the way kidney exchange chains start is with a non-directed living donor. Most deceased donor kidneys are non-directed, but just cause one transplant to happen. So this is an idea that Mike Reese and I and some of our co-authors in California and Michigan put out not too long ago in 2016. And the place where it's caught on in the biggest way is Italy. So here's a discussion of deceased donor chains in Italy. And what they say is, so far, this is writing in 2020, they've enabled 24 transplants, starting with 8 kidneys. So triple the number of deceased donor kidneys employed. 24 transplants from 8 kidneys instead of 8 transplants from 8 kidneys. And a deceased donor chain starts with a deceased donor giving to a recipient in a patient-donor pair who passes it forward, and the last donor in the chain gives it back to the waiting list, the deceased donor kidneys. So, so it's equitable in many ways, and it certainly can increase the number of transplants that you get from a deceased donation, which is particularly important when you don't have so many deceased donations. Now, all sorts of obstacles can be overcome. I had the opportunity to travel to Abu Dhabi last summer as in connection with a kidney exchange, the first kidney exchange between Abu Dhabi and Israel. And as you can imagine, there were political complications that had to be overcome there. But often when there's international exchange, there are also financial complications. Not everyone has the same rules about how to pay for medical care and whether care outside of the country can be covered by the patient's home country. So Mike Reese and me and many co-authors have a paper about kidney exchange overcoming financial barriers to kidney transplantation. And the idea here is as I mentioned, transplants cost about as much as a year of dialysis, at least in the US. But after a year of dialysis, you need more dialysis. And after a transplant, you just need treatment with immunosuppressive if all goes well. So even financial barriers can be smoothed over by savings from increasing transplants. And we've started to see that in the US, where we're able to invite, for instance, a Mexican pair who was highly sensitized, the patient, and who couldn't find a kidney in Mexico, but could take part in an American chain and increase the length of the chain. And so the American healthcare system saves some money when Americans are taken off dialysis and can help smooth some of the bumps that a Mexican patient encounters. So Mexico right now, Mexico has excellent healthcare and healthcare insurance, but they don't pay for transplants in the United States. So there were some bumps that had to be smoothed over, and they can be. And of course, in India, you have some experience with international exchange. Here's also an exchange between Abu Dhabi and India. It involved patients who both came to Kerala, and a different kind of barrier was overcome here, or an additional barrier, not just the barrier of money spending on dialysis, but also the fact that desensitization costs a lot more than compatible exchange. So my understanding is that the pair from the UAE had been offered desensitization in India for 35 lakh rupees, but that getting a compatible kidney only cost about 7 lakh rupees. So not only is getting a compatible kidney better medicine, it's also cheaper, okay, than getting than being desensitized and getting an incompatible kidney. And in developing countries like India, getting an incompatible kidney is more dangerous than it is in the wealthy world, because there's lots of tropical diseases and fungal infections. And so patients who get incompatible kidneys have to be treated with more immunosuppressive drugs. And they apparently do less well than if they can get a compatible kidney as they can through kidney exchange. So once again, not only is getting a compatible kidney better medicine, it's also cheaper. Okay, so I'm going to close with some comments from this paper in 2017 on the first report from India of an international kidney pair donation. And the authors here, the senior author is Dr. Trivedi, so it's particularly appropriate that I close with some comments of his from this paper. The pairs are from Portugal and India. And in the conclusion, Dr. Trivedi and Dr. Kude and their many colleagues, they say, they recommend each state, region, and the entire country of India needs a more robust, organized kidney sharing scheme. An effort should be made to establish a national regional pool of kidney sharing registry, as is the case with European, North American, and other developed countries. Right now, there's no national kidney pair donation program in India. So they call for a national program, and I think it's exactly right that that's what's needed in India, a national program with fewer restrictions on what can be done. Okay, so it's not that India doesn't have the technology, right? When I was India in Ahmedabad in 2019, I saw Dr. Prajal Modi seated at a Da Vinci robot doing a very, very high-tech transplant. So the technology is here, the ability is here, the institutions are here, okay? So let me summarize. India has such accomplishments in transplantation already, so much talent, so much ability, but to more nearly reach its giant potential, India needs to invest in recovering deceased donor organs. That's a big difference from India and the other places that do a lot of transplants. But in the short term, India can build on its accomplishments in kidney transplant by establishing national, not just regional kidney exchanges, by continuing to explore international exchange, especially for the hardest to match pairs, by reducing restrictions on who can be an exchange donor, by allowing non-directed donors and non-directed donor chains, and by allowing some chains, some kidney exchange chains, to begin with a deceased donor kidney. And finally, by reducing financial barriers, by increased investment in public hospitals and government health insurance for organ donors as well as recipients. And I think I mentioned that we've made some recent progress in reducing financial disincentives for organ donors in the United States, and that seems to be a big deal. So that's all I have to say to you today. Thank you very much for having me, and I'm full of admiration for the accomplishments you've already made, and I look forward to seeing you build on them.
Professor Alvin Roth, can we have him online, please?
Yes, sir. Just a second. But at the same time, Dr. Sunil, he can hear every word that we say,
Yeah,
so
sure.
you can continue.
Professor Roth, thank you very much for that talk. You're online. I know that you would have wanted to be here, but you have, I think, some problem with COVID. I would want to say that your plaque and your shawl, we call it, will be sent to you by courier. Would you like to have any comments on global exchange, the way you look forward to this? I know this has been talked about, it's controversial, but would you like to say anything to the audience on this?
Well, I think that India has an opportunity to be a leader in a lot of innovative forms of transplantation, and global exchange may be part of it, especially because there are many expatriate Indians whose family remains in India, although they live elsewhere. So I think India is likely a place where we'll see more efforts to do kidney exchange across borders.
Fantastic. So we do have your citation, Professor Alvin Roth. Would you like to display that? We want to show you your citations, which will be couriered to you. And we are going to take a virtual kind of photograph with you on the background. First time.
We're just going to zoom in on the citation. So if you could point it to the camera.
Thank you.
Thank you. Thank you, sir. Dr. Sunil Shroff, is this concluded? Can I move to the next one, sir, with your permission?
Thank you, Professor Roth.
Thank you.
Look forward to seeing you in person sometime soon.
Thank you, sir. With moving to the next session, I'm going to immediately ask the chairpersons, Dr. Georgie Abraham to please join us and Dr. C.M. Thigarajan to please be the chair. Can I also request Dr. Sunil Shroff sir to please be on the dais as it's his talk and we're all looking forward to it. Can I request Dr. Vivek Kuthe sir to please be the chairperson? From the permissions of the chairperson, if Dr. Sunil Shroff can get started.
Thank you. Great pleasure to be here. And as my slides are being uploaded, may I get started with the permission of the chair? Yes, please. Yes.
We request Professor Sunil Shroff sir, President ISOT, to start his presidential address.
Thank
Over
you.
to sir.
Thank you so much. I'm going to speak to you for the next 20-25 minutes on changing training paradigms in disease donation and its impact. I know disclaimers or conflict of interest. I've been in teaching for more than 30 years and I'm very passionate about teaching. And COVID has taught us some new lessons and I felt that it's important for me to present it to you, to my society. Before I do my talk, as the president of the society, I just want to say a few things about the society. We are an umbrella society of all the organs, including kidneys, liver, pancreas, heart, and so on. Currently, as a society, we have restricted to 2 conferences and a few webinars and seminars in a year. We have close to 1,650 members, and we're growing at the rate of 10% every year, and by 2025, our numbers will cross 2,000. So as we look ahead as a society, how do we add value and get engagement from our members? What can we do as a society to reshape the future of organ transplantation in India? I think as a society, we have an important role to play in policies and regulations related to transplant and organ donation. And we need to be part of, these national bodies who make the regulation. We need to be, as a society, part of it, not as individuals. The recent happenings in, Kerala, where 2 senior professors were transferred for no fault of theirs and transplant coordinators were terminated, and before that in Pune, we need to do protection of our members by creating a legal cell, so some kind of counseling can be done, at least by us. And we need to become a training body, we need to become an accreditation body, and especially with COVID, it has taught us that the online courses can do miracle, and we need to look at this, how do we create these online courses as a society? And this is what I'm going to talk to you in the next 20 minutes. If you look at the disease donation numbers in our country, from 2012-13, the numbers started rising up to 2016, and we did about 722. After that, we plateaued, the numbers plateaued. I think, to take care of this demand, we need to do, need to look into it, look at the various reasons where we need to improve ourselves and how do we go forward. The potential for organ donation in India is huge. Unfortunately, due to our roads being so chaotic, we have a lot of deaths on the road, almost 8.4 million. 1 to 4% are, due to brain injury. And every day we have 400 deaths on the road, 147,000 road traffic accident deaths, 67 head injuries, potentially 95,000 brain deaths, all young. So we are not even converting 1% of these to potential organ donors. The issues are lack of awareness, of course. This has been there for a long time. Some of the cultural barriers, mistrust in the healthcare system, but this is not new. This has been there for more than 30 years. We have been creating some wonderful green corridors on the road, This is a green corridor where a heart is being transported, and you see how the public start throwing flowers on this van. The good feel factor plays in. But the need of the hour is to create green corridors within the hospitals. Of course, that will help a great deal, because the first barrier is knowledge deficit. There's poor knowledge of brain death, of identification and certification. The system failure. We don't have standard operating procedure because organ donation in brain death is complicated. We need to create SOPs. And then there's lack of support for donor families. They are not able to handle their grief, sudden death of a young person, and the medical legal complexity of the situation. So we need to look at how to, at least do training our professionals to better handle these things in the hospitals. And I'm going to share my experience with face-to-face and online training and the impact on disease donation it has had. You all are aware that I'm associated with an NGO called Mohan, which creates awareness. There's counseling and there's networking, but training is one of our key areas which we've been involved with in the last 15 years. We have been doing training from 2009, and you all know this, that we need to have ICU trained staff, we need to have coordinators, we need to train surgeons, and we need to also do police sensitization because most of our cases are medical legal. So we have been doing training from 2009 of ICU, of transplant coordinators. Police we started in 2012, and organ retrieval we started in 2015 with Oxford Group, with Dr. Sonal Asthana in Bangalore. And then came COVID in 2020. It was a difficult time. But a lockdown accelerated the adoption of technology to deliver education and healthcare. And it did wonders in COVID for us. The online training, actually from face-to-face, we moved from teacher-centric to student-centric education. Pre-2020, we did face-to-face and a very few new online training, but post-COVID, we did just online and hybrid training. Over the years, we have done about 92 training workshops, 75 face-to-face and 17 online in the COVID times. In the COVID pandemic, we did 21 training workshops, 4 were only face-to-face, 17 were online. And look at this, in the 17 workshop which we did, we trained 653 candidates. And if you look at this, the convenience of doing online training and convenience of the candidate to take these courses, we had candidates not only from India, but adjoining countries, and including Spain, because cost of training was only about $30, $40 compared to thousands of dollars of training in other countries. We have a very structured training program which has got involved on medical, legal, ethical aspects, grief counseling and so on. And these are some of the training modules which I would like to show you. We have, in every module, we have text-based. This is talking about types of transplant, the kidney exchange, graphically done. Then we have PPTs. And these PPTs are interactive. They are not just any PPT. A person has to read them and answer the question as they are reading this. This is about brain death, science of brain death. And then it asks which part of brain is damaged in brain death. And then they have to fill in the blank, brainstem. And then it will move on to the next module. And once they continue, so it is not just PPT. Here it's about preconditions and exclusion of criteria for brain death certification, preconditions, exclusions, what tests you'll perform, and then there'll be a question which will come up after they've read this, asking about in brainstem death, the committee should ensure that the following reversible causes of death is excluded, and if this answer right, then you go on to the next one, explaining the various reflexes, where they are from, what is vestibular gag reflex, what is gag reflex, and so on. Very graphically done, interactive. And then they again have to do an interaction where they have to drop these, cartoons into the right boxes of the reflexes. And once they do that, and once they get it right, they'll go on to the next kind of, slide on the PPT. And this seems to be very successful, and people love it when they do this, and the impact is much higher in this training. And then we have video lectures of faculty, and this is a lecture on BK virus. There's sound to it, but I probably can't hear it. And this is by Dr. Anish Chandrakar. We use green mat, we use 2 cameras, and we invest in this technology to capture these videos so that student can see it in their own time, and in the end, there's an assessment of the students. They take MCQs in the end, and the results are phenomenal. We have more than 95% pass rate compared to previously we used to have 80, 75, 80%. So this really, I think, is the way forward to look at training. Let me just take you out, sorry. We have 70 modules on those 4 basic topics, and we have 60 video lectures. We do contact sessions. Contact sessions were not possible during COVID, and I'll tell you what we did about that. We have assessments, of course. What is difficult to teach online is soft skills, develop interpersonal skills, emotional intelligence. This is the soft stuff is actually very hard stuff to teach. So what we did was we started creating simulation videos online to train them, and this is a video telling a transplant coordinator talking about organ donation with the family. These are actors we hired and shot it in a studio. Can you put sound to it, please? Very nicely done. And they've done a very professional job. So we have created 6 to 8 such videos for the candidates to look at and simulate those soft skills. What are the challenges of online training? There are challenges in connectivity issues, available of desktop or laptop, lack of personal space, and especially of women to have work-life balance at home. So we did a survey and asked them, how often do you face connectivity problems? And last month connectivity problems were there in 50%. We asked them about what kind of system they use. Was it desktop, laptop? Almost 60% were using mobile phones for e-learning. Was the course engaging, friendly? 92% said yes, the content was very engaging. And 90% would recommend to others. And when we asked them, what is your preferred method of learning? 60% said online and hybrid, not face-to-face. So this is a revelation. This course, which we have created, has had a British Medical Journal Award of South Asia in excellence of medical education. And this is Dr. Somna Naveen who received the award. After that course, they form a WhatsApp group and they ask questions. When there is a brain death, this is a question about which form to use for brain death and so on. And then there is a further interaction. In COVID-19, what is the impact? Before COVID-19, in 10 years when we did training, we had done, our transplant coordinators who had been trained had done about 1,900 odd disease donors, resulted in more than 9,500 organs and tissues. In COVID, 126 disease donors were done, 655 organs and tissues. In pre-COVID, we were doing ICU workshops face-to-face. 655 healthcare professionals have been trained in 16 workshops. But in COVID, again we went online, and this is a brain death video, again on green mat, by Dr. Naveen Jayakumar. He talks about an anatomy of the retina. Can you put sound up a little bit?
Humani, or the fabric of the human body, written by a very celebrated anatomist by the name of Andrea Vesalius. And this is Andrea Vesalius. And my story on an autopsy on a very important person in Spain. However, when the chest was opened, the heart was still found to be beating. And that was a bit of a disaster for Vesalius, because the relatives of this patient thought that he had killed the gentleman, and Vesalius was forced to leave Spain. Which brings us to an interesting question, as what Vesalius might have asked himself, and what we ask ourselves even today.
So,
is what
very engaging kind of lectures. We rehearse them, and then we take it forward. We also do a legal course for them. This is a PPT on Transplantation of Human Organ Act by Dr. Somna Naveen, and then we give salient court cases, judgments on which have happened in the field. We also have developed apps, brain death certification app for the intensivists, and a donor optimization app, along with the NHSBT. These apps are available freely downloadable, and they are being used even in Europe for that matter. Retrieval courses for surgeons, we have a tie-up with Oxford Group. They come as faculty, and we have trained in about now 6 workshops, 1 took last month. And this again won the BMJ award. almost 40% of the candidates are from public hospitals in this workshop. These are live workshops on wet lab, cadaver lab, where they learn about retrieval and about transplantation. How useful was the course, we asked, and 96% gave a very high score. The impact of these surgical workshops, we have many people who have gone back who have never done a cadaver donation and did organ recoveries, be it private, be it institutions, many recoveries. And and they've done 18 heart transplants performed after the workshop, never done before, and 2 were performed in a government institution. This is Dr. Ratnavelu, he did a transplant, heart transplant in Madhura Medical College. So when COVID came, then we thought, how do we train these skills? So we spoke to IIT Chennai, and we started looking at virtual reality to develop surgical skill training for our surgeons, and how to use virtual reality in surgical skills training. And simulation-based learning is the way forward, we feel, because when you use simulation and virtual reality, it helps the trainees to master the skills without the need to oversight in the operation theater, helps in easier skill transfer, making trainees proficient and competent, and provides a low-risk environment for repetitions and maintenance of their surgical skills. So great way to go forward. We've been doing police training as well. In Tamil Nadu, we have trained more than 7,000 police officials. By the coordinators who are very good at training, a lot of engagement we get. We also train police officers in other states. And look at the impact of police training. The post-mortem delays were reduced from 24 to 8 to 12 hours after training. Posters in Tamil were put up in police stations. And the biggest impact of this training, which other states can learn, was the DGP of our state appointed a nodal officer for organ donation in case of problems. So this was a great impact. And we've done short-term courses now for general public as well. This is a gift of life, one-day certificate course for general public. We have one. We have short courses on taking care of kidneys, liver, heart, and so on for the general public. And here what we're doing is we're trying to use gamification techniques to get the engagement from the public. And this, I'll just show you some. This is a quiz which they do, just matching and putting the kidney together after they've done the course, just for a better understanding. So the gamification works very well. It helps the kids, they love it, especially the children. And this is a memory game where they put things together on a board. This is what we're using for general public. Again, getting engagement these days is a challenge. So gamification is a way forward. And once we master this among general public, we hope to bring it to our doctors and as well. And this is another one.
Kidney.
And there's a lecture,
Kidneys
short
are part
lectures,
of the
5-minute
excretory
lectures
system.
in a neutral voice.
Besides the kidneys,
so anybody can take it from anywhere in the world.
Ureters,
So we have combined all this together
and urethra.
for a 4 to 4 hours course on how to take care of kidneys, how to take care of a liver, how to take care of. So this works extremely well. And we have good uptake on these courses, on short-term courses. So in summary, as we look ahead as a society, I feel ISOT has a key role to play in the growth of transplant medicine in India. I think training and accreditation should be high on its agenda. I saw the LTSI doing it so well, a couple of days back, and I'm very happy to see them go forward, and we can do some tie-ups with them. I've been speaking to them, and we should do it. We should put our logo. We should do it together. Getting accreditation from universities is extremely difficult, but most of these people are postgraduates. They just want to acquire some extra skills. So we don't need to necessarily go to universities. So this is an opportunity for our society to look at training and accreditation as a big way to engage our members. COVID-19 pandemic has changed the training dynamics totally. Most people are very comfortable doing training in their own home, in their own time, and having some contact lessons on the weekend when it's convenient to them. So hybrid teaching with online courses is very convenient and cost effective and the way to go forward. Thank you very much. This is my team of Mount Foundation, which worked very hard on these things. Thank you. I'm glad I finished before time.
Chairpersons.
Thanks, Sharaf. Your hard work has done a good job. You've been on it for over a decade now. And whatever we have done in South India, I don't think it can match what our colleague has done in Ahmedabad. I think he should give us an idea of how he is able to do such a great work in Ahmedabad. We are trying our best. Anyway, everything is because what Sunil has started in Chennai, and trying our best to follow that. Thanks, Shubham.
Thank you, sir. Thank you for your kind words.
I just wanted to recall that I still have the pictures. 1997, we conducted the Indian Society of Transplantation. Many of my colleagues were there. We started planting trees at that time. The young Sunil and the old me are standing there along with Sunil's boss mentor. What was his name? From Britain.
Chris Rudge.
Chris Rudge. And we were, Professor Soundararajan is also in that crowd. And from 1997, we have gone a long way. And I think this is the combined effort of all of us. I think that we all deserve the credit for that. And it should be to the patients, their relatives, as well as to the donors' families, who have kindly donated their organs. And those plants have now become trees in SRMC campus. Although both of us have left SRMC, they stand there robustly, implying what we have done some 25 years ago. Thank you.
Thank you.
Thank you so much. With that, we conclude this session. I would like to personally thank Dr. Sunil Shroff for saving a few more minutes. Thank you so much, sir. It was always a pleasure with you. Thank you. As we all know, being on time is a good thing, and since sir has saved 2 minutes, we are going to be just giving a quick quiz. In the meanwhile, can I have all of your eyes onto the big screen for the quiz? We've got Dr. Kapil. Dr. Faizin is going to be there for the quiz. Can I request all of you to again open your phones? Again, requesting all to please scan the QR code.
Request everyone to join quickly. Please, you can scan the barcode also nearby your screens also. Here we go for the question. We'll wait for the 10 seconds to answer. I think most of the people have answered. The maximum response goes to option C. Let's see what's the correct option. The answer is C, Cryptococcus pyogenes. And Dr. Srinivasan Muthukrishnan won the quiz. Congratulations, sir.
Thank you so much. And
you have to collect your prize at 5 p.m. at TNS stall in your lunch area.
Thank you so much. This was the only time that we could do only one question, but these questions are going to be coming in between. I would immediately like to call the chairpersons for the next session. Can I request Dr. Sanjay Kolte sir to please join us on the stage along with Dr. Shankaran Sundar and Dr. Harsh Vardhan as the chairpersons. Can I also request our speaker, Dr. Krishna Menon. And anyone who loves him calls him Krish. Not from the movie though.
I think we are into an interesting session, simultaneous kidney liver transplant. I think this has been going on for quite some time, and I myself got involved in this about 5 years ago. My experience as a nephrologist is limited to few cases, but nevertheless, I think we have Krish here, and I had the opportunity of meeting him yesterday in the Stinkle Mod Club, and glad to know that he is taking over as the president of the British Transplant Society. I was very upset when Rishi Sunak lost the election as Prime Minister, but I'm happy that we have Krish taking over as the British Transplant Society President. I request Krish to go ahead with the topic today, and my co-panelist, co-chairman will take over later on. Krish, thank you.
Thank you very much for the kind introduction. I think after the tour de force on pediatric liver transplantation by Mohammed and education by Sunil and Alvin Roth on paired exchange, I think this is a very niche area, very small group of patients who undergo transplantation as a simultaneous liver and kidney. They pose logistical challenges, and they're also sometimes difficult to actually get right. And what I'm going to share with you is some of the policies in the UK for simultaneous liver kidney transplant, the UK experience, and some of the data that exists in terms of doing this operation, particularly for simultaneous liver kidney transplant. So I'm going to go through some of the indications, the UK policy, because the UK policy has changed over time in terms of organ allocation. And what I'm going to do is also not only share the UK outcomes, but some of the other outcomes worldwide in terms of simultaneous liver kidney transplant. And I'm also going to share with you what is the risk of rejection in these patients. Does frailty have anything to do with the outcomes in these patients and the risk of delayed graft function in SLK transplants? So commonly we do it in the UK for polycystic liver and kidney disease, but you also do it for patients who are decompensated with alcohol-related liver disease and renal dysfunction and NASH and hepatorenal syndrome and primary oxaluria. When you focus on the patients who got renal dysfunction in the context of liver disease, the underlying factors that determine how well they do is the duration of the pre-transplant dialysis, and if it's more than 90 days, they tend to do worse and require a liver transplant and a kidney transplant. The age at liver transplant does matter. The presence of comorbidity, particularly type 2 diabetes, and if they're having a retransplant, again, they're higher risk of renal dysfunction. Abnormal renal imaging pre-transplant also is an indicator of how poorly they're going to do after a liver alone transplant. So you can use various algorithms in terms of chronic kidney disease in these patients. But if you've got end-stage liver disease and if you've got acute kidney injury, the duration of dialysis of less than 6 weeks, you'd probably go for a liver transplant alone. But if your duration of dialysis is more than 6 weeks, then you probably go for a simultaneous liver kidney transplant. On the other hand, if you've got end-stage liver disease and chronic liver disease, and if you've got a GFR, that's EGFR, that's more than 40, again, you'd probably go for a liver transplant alone. But if you've got a GFR that's less than 40, then the determining factors on whether you go for an SLK are presence of proteinuria, diabetes, hypertension, and the older age group, more than 65 years. If you've got a kidney biopsy that shows renal dysfunction or poor kidney function, then again, you probably end up with an SLK. If you've got a small kidney on an ultrasound, that again is a predictor of whether these patients are going to require a simultaneous liver kidney transplant. So what happened in the UK in terms of policy change for SLK? In 2015, there was a concern that there's a potential disadvantage of patients who require a liver kidney transplant, because in February 2015, 52 patients were waiting for such a transplant, and almost 20% of them had waited for over 2 years. Now, therefore, the Liver Advisory Group, which is the sort of underpinning body for liver transplantation, and the Kidney Advisory Group, likewise for kidney, agreed that something had to change in terms of the ODT, which is the organ donation transplant hub operations, to readily facilitate combined liver kidney transplant. So a new process was implemented on a trial basis. So what we decided was the hub operations would delay the offering of one kidney from a donor after brain death for up to 60 minutes, during which time the liver zonal center could declare if they wish to have, if they had a recipient who would want a liver kidney. In other words, have a kidney accompany the liver. Now, this has allowed liver zonal centers to actually have a priority in considering liver and kidney patients with the knowledge that a kidney will be available to them if needed. rather than be already committed to a kidney recipient. And this change in policy went for a 3 years period, but unfortunately then the liver allocation changed. Now, just to give you a background, I talked about this day before yesterday. So the liver allocation policy was traditionally based on a zonal system. In 2018, we decided to change that to a transplant benefit score. In other words, offering the organ to the patient who required it the most. In other words, who's likely to benefit the most after transplant. Now, that's called the TBS system. So if you've got a TBS score that's high, and if an organ becomes available, it might be in Edinburgh, but if you're in King's, and if the King's recipient is the one with the highest TBS, then the organ gets allocated to the King's recipient. So that was a major change in the policy. So therefore, we had to rethink the policy in terms of SLK. And what was decided was with adult DBD donors, one kidney would be reserved for a liver patient only if one of the 3 ranking recipients on the elective list required a kidney. So that was a key principle on which the SLK was decided. The kidney would become available for kidney recipients after 60 minutes or once it's been declined for a liver kidney recipient. So in other words, we tried to marry up the 2 allocation policies. The offer was provisional and subject to not being high priority patients on the national kidney list. So if there's a high priority patient on the national kidney list, that kidney would go to the kidney recipient. And this is how the SOP looks like in terms of King's, in terms of what happens. So you can see it's a logistical challenge because certainly in King's, we've got the liver unit that's based at King's and the kidney unit is based at Guy's and St. Thomas's Hospital. So the surgeons come from across the other side once you finish the liver transplant to do the kidney transplant. So almost a whole day is gone in actually doing this transplant. So once the offer comes from the NHSPT hub, and if it's a liver and kidney offer, the first thing that happens is the coordinator discusses it with the liver surgeon. And if you decline it, then you phone the hub and decline. If you go ahead with the offer, then the next thing that happens is key. You phone the renal surgeons and you decide whether you're going to go ahead with the liver kidney. And once you do that, then you go for a virtual cross match, and you're going to do a full cross match. Then obviously you would send the tissue along with the organ for testing before you decide to go ahead. Now, this is the kind of waiting list that we have. It's a very small group of patients, 36 patients who wait on a list for a liver kidney transplant. Now, I'm going to go straight to the outcomes because there isn't much data in these patients. So if you look at the unadjusted 5-year survival for patients following this change of policy that we did for SLK, if you look at liver-only recipients, which is about 4,800, and the SLK group, which forms just over 100 patients, the 1-year survival is no different between the liver-only and the simultaneous liver-kidney transplant group. Similarly, there's no difference for the 5-year survival in patients who have undergone liver-only transplant or the SLK transplant. If you look at the 5-year transplant survival, again for liver-only and SLK, you can see the 1-year survival is no different, and so is the 5-year survival. So you get very comparable overall survival in these patients. If you look at the graph survival, again, you can see for the liver-only and the SLK patients, the 1-year and 5-year survival is over 90% in terms of SLK in comparison to liver-only. So we wanted to also look, having instituted all these changes in the policy, are we actually harming the kidney patients by doing this? So we looked during this period and assessed whether there's an impact on the kidney recipients who may have missed out on a transplant as a result of a kidney being used in a liver kidney patient. So the kidney matching runs for 5 kidney transplants since May 2021 were examined, and 2 were for 1 high priority patients, and 1 of the 2 patients had been transplanted. So in summary, we found that there's no impact on the kidney patients after a change in policy to give patients priority in the SLK pathway. Same way for DCD, we looked at the kidneys that were offered, 228 out of the 231 donors where livers are accepted. And this is a slight, we're kind of a bit regressive in that mode because we're not being very proactive in taking on DCD organs for doing an SLK transplant. There's been a reticence from the kidney group to actually use a kidney from a DCD donor. So hence, we've not disadvantaged anybody from the DCD pathway either. Now let's look at whether, moving on to the global data, is there a center volume effect? In other words, if you do more of the SLK transplants, do you tend to get a better outcome? And this was a paper that came from the Ohio group, and you can see here that what was shown was that they tried to look at the center size and see whether there were any survival differences in simultaneous liver kidney transplant and liver transplant alone for the listed patients. And again, they looked at all patients between 2002 and 2015 and looked at the post-transplant survival. And you can see here that there was a clear center volume effect. And what they found was in the study period of over that 10, 12-year period, if you did more than 30 SLK transplants, your outcomes were better as opposed to doing less than that. And what was interesting was that if you had cofactors such as diabetes, again, the outcomes were very significantly different. And again, this is shown graphically in terms of the Kaplan-Meier curve. If, again, you looked at the 30 plus over the time period, but equally, if the center was progressive and did 10 more transplants every year during the study period, you found that incrementally, the survival outcome was much better for these group of patients. In other words, the hazard ratio dropped, and that's again reflected here. So there is a clear center volume effect because the number of patients who undergo SLK transplants, as you can see, are very small. So risk of rejection. Now this is data from King's that I'll share with you, where we looked at the kidney rejection following simultaneous liver kidney transplants. And you can see here, big difference in the type of patients we transplant. Vast majority, 19 of the 27 patients, are actually polycystic liver disease. Now they are not very sick in terms of their liver disease, and often these are transplants that are not very difficult to do from a liver point of view. And what we wanted to see was, doing these transplants, does it increase your risk of rejection? And you can see the spread of indications that you can see there: alcoholic liver disease, cystic fibrosis, PBC, NASH with renal dysfunction. Now you can see 7 patients had rejection, of which 4 had antibody-mediated rejection. And again, what was key was that all these patients who had antibody-mediated rejection had DSAs that were over 10,000. And you can see here that if you look at those specific patients, you can see here the DSAs were all over 10,000 in these patients. And clearly, what was interesting was once they get to post-transplant at 1 year, DSAs drop off and they get after the treatment. So you can see here 2 of those patients, you can actually have undetectable DSAs, and the rest are on their downward trend. So in summary, what we showed was that patients who get standard immunosuppression, which usually consists of tacrolimus, MMF, and prednisolone, the overall acute rejection was about 33%, and the median EGFR for these patients at 1 year was 52, which is still very acceptable, and at 2 years was 49. But there was a clear risk of AMR in the SLK group, despite increased immunosuppression, but this could be effectively treated by plasma exchange and intravenous immunoglobulin. And again, that was reflected in the DSAs at the 1 year post-transplant period. What about frailty and outcomes in SLK transplants? And again, you can see here the Karnofsky Performance Index, which is a measure of physical frailty, was looked at by the Indianapolis group, and they showed clearly that if you had a KPS which was C, and this is looking at over 5,500 transplants, the 1 year waitlist mortality was comparably was lower in the A group, but as you went to the C group, it was over 32%. And clearly there was an increased waitlist mortality in these patients. The 1 year post-transplant survival likewise was slightly reduced for patients with the KPS C. If you look at the risk of delayed graft function, now this is a very interesting study that was done from Jennifer Lai's group, from the UCSF group, and what they did was they actually looked at over 6,000 patients and grouped them into 4 groups. So the comparative groups were kidney alone transplant, simultaneous liver kidney transplant, but those with a MELD less than 25, simultaneous liver kidney transplant with a MELD between 25 and 35, and simultaneous liver kidney transplant with MELDs over 35. And the reason I find this paper interesting is because they tried to dissect out the group of patients that are the more difficult ones to decide whether you should do a liver alone or whether you should do a simultaneous liver kidney transplant. So again, you can see in the comparator groups, you had about over 1,400 patients in the kidney alone group and over 1,500 patients in the MELD less than 25, 1,800 in the MELD between 25 and 35, and about 1,300 in the MELD over 35. And again, interestingly, you can see here that the patients who had MELDs between 25 and 35 and 35 and above did worse in terms of SLK transplants. And what they were looking at is whether these group of patients would benefit by having a liver alone and use kidney as a safety net, because UNOS had just introduced the safety net principle in terms of kidney transplantation. And again, if you look at this in terms of the kidney donor risk index, and what they did here was the patients who had the liver transplants were being offered organs with very good quality livers. So they matched it to the KDDRI, and once they looked at the KDRI, they matched that to the liver donor index and looked at whether or not patients who had MELDs less than 25 did better. And the cutoff they found was 25. So in other words, if your MELD was 25 or lower, you actually had lower risk of renal dysfunction if you had a simultaneous liver kidney transplant. But the moment your MELD went over 25, despite you getting a very good liver and a good kidney, your risk of actually developing renal dysfunction or delayed graft function was much higher in the group. So in the context of the safety net, they concluded that if you got a high MELD score, you're better off going for a liver alone transplant and follow it to the kidney transplant using the safety net principle. So in summary, the UK experience of simultaneous liver kidney transplant versus liver transplant alone, there was no difference in the outcomes. I think center volume does play a role because these group of patients are not, small volume centers do not do these often enough. There is a clear risk of delayed graft function, particularly in the high MELD group from the data that I presented. The risk of rejection may be higher and could be easily treated, particularly if we get AMR. And there is some suggestion that frailty correlates with worse outcomes for a higher KPS. And once again, thank the organizers for the invitation. Happy to take any questions.
Thank you very much, Dr. Krish, for a wonderful and a very clairvoyant talk on this very important topic. As a surgeon, I would like to know from you the surgical challenges in this kind of a surgery, because for a liver transplant, the details of a surgical steps are different. For the kidney, any specific modifications with regard to this placement of the kidneys when you do it simultaneously with the liver?
So that's a good question, because we started off actually doing it through the same incision. So from the liver transplant incision, the surgeons would do the kidney transplant. But what we found is actually it's better off when you use a separate incision. So the kidney transplant surgeons, because when we used to do it as liver surgeons, we used to do both initially. But then certainly at King's, we changed the policy. I think when Mohammed was there, the liver kidney were done by the liver transplant surgeon, because some of the people were trained in kidney transplant. But I think around about 2015, we changed our policy, and the guy surgeons come in to do the kidney, and they use a separate incision for doing the kidney transplant. So we finish the liver transplant and leave the abdomen open. They come and do the kidney transplant, and then we finish the closure. So I think, in a way, it works well, but you almost lose a whole day, and other transplants can't be done. So it's a logistical challenge from that point of view. But the number of patients we do, as you saw, 27 over a 5-year period, so it's not very many.
Sir, as we know that advent of lumasiran has changed the history and prognosis of primary hyperoxaluria. If timely treated and timely diagnosed, then it can prevent kidney failure, and it can prevent simultaneous liver and kidney transplantation in primary hyperoxaluria.
I mean, we did only one patient, as you can see. There's only one patient in the 27 at King's. So
we can take 1 or 2 questions or comments.
Wonderful lecture. My question is, like in a live related program where we are taking kidney from the liver, live liver and from the live donor from liver and kidney. So like we have done a good number of cases, and my suggestion and impression is that let the kidney, liver transplant go, and after few days when patient is stable, then do the kidney transplantation, because after liver transplantation patient is unstable, his inotropes are going and blood transfusion and other things are going, and at that time putting the kidney, it compromises the kidney functions. And so I think in live later program it is better to always stage it in a planned way rather than rushing at the same day.
Yeah. Unquestionably, that's the way to go. So we've done living donor in a polycystic setting in a staged manner, but in a cadaveric, we often do it together, one after the other.
But in a cadaveric, now you have option, like you can put the kidney on the pump for 24 to 48 hours. By the time liver problem will settle down, and then you do it.
But again, as I showed you, at least in our practice in the UK, a vast majority of patients are having the transplants done for polycystic. And polycystics, usually they are not very difficult transplants to do. You get a liver put in, it's almost always going to work straight away. I think the challenges come when you're going to do a simultaneous liver kidney transplant in somebody who's got either alcohol-related liver disease with high MELDs or UCALs. Those are the ones where you have to rethink. And certainly in the UK, we've gone for very, very few patients will try and do simultaneous. We'll try and do the liver first and use kidney transplant as a salvage almost. So if they persist with dialysis after that, because in the proportion of patients, both with alcoholic liver disease and other NASH, for example, the renal dysfunction may get better once you get the liver in and the renal and the liver failure improves. So there is a chance for them to get better and they may not need a kidney transplant if their EGFR continues to improve. But certainly in the cadaveric setting, for a vast majority of our patients who are polycystic, we would just do simultaneous, sequential, one after the other. Thank you.
Krish, I saw your Dr. Padma Shri Balla, please, my husband.
I just wanted to have clarification, like we have done almost 6,000 transplants and predominantly liver related, and quite a few polycystic kidney disease transplants we have done, but in none of our patients we did combined liver and kidney transplantation, and actually none of the patients, almost maybe around 5% of patients we did polycystic. Not even a single patient had chronic liver disease because of polycystic kidney disease. So I don't know, you mentioned that is the first as the indication.
Well, that's what is our practice, but again, you have to look at the entire UK practice. If you look at, we have a lot of patients who are not presented here because they're not SLK and they're often liver after kidney because they've had their living related sometimes kidney transplant already done because the EGFR was dropping, and many years down the line they come with a polycystic liver, probably from a size point of view, satiety point of view, and then they have a liver transplant alone. So liver after kidney is more common, but there is a group of patients who you have a low GFR and you also have a large liver with polycystic liver disease, with the burden of disease is such that you cannot treat it by fenestration. So we do use other methods like laparoscopic fenestration of cysts, debulking, resection. All of those options are given to these patients before actually considering a liver transplant.
I don't know, maybe what is
But
I'm sure other Indian centers also must be having same experience.
yeah, and I think, it's a fair point. It's just a difference in disease. And I think the other thing to factor in is that in your polycystic liver and kidney disease, as I said, your assessment is based not probably on the liver dysfunction, but on the burden of disease of the cyst. Can that be treated by fenestration? Can that be treated by resection? So we go through all those options and then go for an SLK if it doesn't work.
Yeah, just to answer Dr. Bhalla's questions, we had two such situations. Kidney transplantation one was done. After that, patient has an inadequate liver function and slowly deteriorating, and we tried to find a liver donor for them, but the family did not have anything, and both the patients finally died in 2-3 months later.
Krish, I had this, I had a colleague of mine, I don't know, a guy called Olit Selvan. He was a hepatologist, used to work with me, and we had a complicated case of cross-matching positive for a lady for a long time. She was not keen on a desensitization protocol, but she had read somewhere that you could take an accessory lobe and do a simultaneous liver kidney transplant. Do you think that's an option?
Accessory lobe, you mean to say? Oh, okay.
For a simultaneous accessory lobe liver and kidney transplant for a cross-match positive recipient.
So again, we've not had much experience with that, but sensitized recipients, we got a protocol that we use for kidneys in the UK. So that's a very standard protocol that's used. But we've not used partial liver, is that what you're suggesting, as a kind of, to combat the cross-match?
Correct.
Yeah, no, we have not had that.
I saw 1 or 2 cases in the literature. Theoretically, it sounds good.
Because the data is there, some scarce data which suggests liver is protective, but that's not borne out in large bits of evidence. So,
thank you.
Thank you.
If there are no comments or questions, we can close the session. Thank you.
Thank you so much. With that, we conclude the session. I would again request all of you to have your eyes onto the big screen for the barcode. so that we can get started with the quiz again. In the meanwhile, I would like to till you all are scanning. Let me make a quick announcement. The oral presentations that were supposed to be happening in the lunch area from 2 to 4 has been shifted to 3 to 5. So just a 1 hour push ahead. At the same time, all the delegates can collect their kits from the exhibition area along with the newsletter that has been launched. So you can collect your kits, newsletter at the exhibition area. The oral presentations have been moved from 2 to 4 to 3 to 5. So the updated time is 3 to 5 oral presentation at the lunch area itself.
Let's move on to the question. We have 10 seconds for the responses.
If you look on the right side corner, we can see there are 45 participants, out of which only 42 have answered. There are 3 who, yes, now 46. Here we go.
So option A has the maximum responses and indeed is the correct answer. Now Dr. Srinivasan Muthukrishnan has won the first prize.
Again,
congratulations.
I think this is the second time. It's like a streak. So congratulations, you're doing. Yeah, so you're gonna get 2 gifts. I don't know, Dr. Kapil, are the gifts same? Then somebody else, he can trade it with somebody, right? All right. Thank you. Would you like to go ahead with one more question? We have time. So everybody be logged in. The question number 2 comes onto the big screen. In the meanwhile, as the quiz is going on, can I just request the chairpersons to please join us on the stage, Dr. Krishna Kumar, Dr. Sanjay Kumar Agarwal, and Dr. Vivek Kuthe sir. Can I also request our speaker, Dr. Atul Goel, to please join us on the stage?
So here we go with the question.
In 10 seconds,
Yes, 10
your
seconds
time is going
for
to be
the
up.
responses.
7, 6, 5, 4, 3, 2, 1. Up. Time is up.
Option B is the correct option. Dr. Asim Singla, congratulations. You can collect your prize from the TNS counter. Thank you.
TNS stall at 5 o'clock. Now we have the presentation and over to the chairpersons.
Good afternoon. It's really honor to chair a session in which Professor Goel is speaking. He is, this audience doesn't need introduction. He is Director General of Health Services. He is also has been Director Professor of Internal Medicine in Lady Hardinge Medical College and RML Hospital. But for this audience, what is more important is that he is the appropriate authority as far as Transplant of Human Organ Act is concerned, a thorough clinician and very active in bringing the changes. So if you are expecting any possible change in the transplant law and rules, he is the person who will be initiating. Dr. Goel, please. He is going to speak on myths and reality, organ transplantation.
So, thank you, Dr. Agarwal. Actually, I didn't know how to name my topic or how to get into this audience because I'm a misfit here. I'm not a surgeon. Leave aside transplant, I'm not even a surgeon, I'm a physician. But I guess physicians tend to have a broader outlook to everything. So my talk would encompass certain things where I would invite the interest of the private sector. And one thing that needs to be remembered is that we can't work in silos, not the private sector, not the government sector. And handshake requires 2 hands. If one hand comes forward, there could never be a handshake. So it has to be bilateral. Now, at the apex of the highest body that can offer or that offers technical advice to the Ministry of Health and Family Welfare, the Directorate always is in a dilemma, and the dilemma is multifold. On the one hand, National Organ Transplant Program is looked after by NATO, which comes under Directorate General of Health Services, which means that Directorate has the responsibility to successfully encourage the transplant program across the country. On the other hand, there are two more things. The Directorate has to successfully prevent organ failures also. We cannot ignore that organ failures need to be prevented for reasons I would talk separately. And we also ensure that any transplant program is available to the poorest of the poor. So Directorate has these dilemmas when it comes to promoting organ transplantation in a mission mode. And this cannot be done. Well, organ transplantation for the poorest of the poor cannot be done without a disease donor donation, without, say, cadaveric transplants, which will happen only when NATO will be able to achieve optimal organ donation from diseased donors. A lot of people are already into it, especially down in the west and in the south. However, there are certain parts of the country which are lacking far behind, and there are reasons for it. Some of those reasons will be covered under myths, and we know that one disease donation can save many lives when compared to a live donor donation. So we have a lot of problems and bottlenecks everywhere, including the areas where transplant is doing well. One is the awareness of need and usefulness of donating organs. There are a lot of people who are still ignorant, and especially in the eastern part of the country, people still don't discuss it. There are number of myths surrounding donation of organs. Then there is a question of uniform certification of death, and to remain confusion around postmortems in case of accidental death. There are bodies which need to be on board. That includes the law enforcement agencies. You see, in case of accidental deaths, postmortem becomes an issue. So unless the police and judiciary is on board, we can't really make headway into it. Then increasing the number of retrieval centers. There are retrieval centers which are doing a wonderful job even in the government sector, for example, PGI, Chandigarh, or All India Institute of Medical Sciences, but there are places which need to pick up. Despite being huge centers, they don't retrieve even a single body. So that's a question of concern which Directorate needs to address, and we are in the process of doing it. Then developing clear guidelines of retrievals at center in every place, in every state. We need to develop these guidelines in the Directorate. We have certain guidelines which need to be changed or modified because our major hospitals are still not aware of the guidelines. They are not aware of the help they get from the NATO or the help they get from the center in terms of organ retrievals. Then establishing adequate training centers for transplant, retrievals included. Retrieval is not done by just any surgeon. So the surgeons who would be doing it, as of today, people who are doing the transplant want to retrieve the organs themselves. So there has to be a retrieval team in every institution which needs to look at it. Establishing a transplant system for organ allocation that is not determined by human greed and supremacy. This is a question which is going on in centers, and I get informed that certain times allocation occurs within 15 days. At other places, people wait for 3 years to get an organ. So there has to be a distinctly transparent organ allocation system. We also need to remove bottlenecks in organ transportation after retrievals. Legislations including their universal adoption sometimes affected by political and or social discourse. Lowering the cost of therapy post-transplant. This will be another important thing because it's just not about a single event doing a transplant. It's a lot after that as well. Well, I will not go into history because I think it was discussed yesterday, but we have a huge history and we sometimes term it or call it as mythology. It is not mythology, it is all documented. So we need to respect that and so go on for this organ transplantation. As we talked in the last slide, or you saw in the last slide about Vajra. Vajra is depicted in the Paramveer Chakra also, the highest gallantry award. And this Paramveer Chakra was designed by a Swedish-born lady, Savitri Bai Khanolkar. And it was a joke. one politician in a speech said that the first organ transplantation that occurred in India was Ganesha's, and people made fun of it. But I don't think we should make fun of anything. We should not make fun of anything. We should respect that and move forward. Now, myths surrounding organ donation are: one, it still is there. Hospital staff members don't work as hard to save your life if you're an organ donor. That's not true. That is absolutely not true, because the hospital staff which is looking after you as a patient doesn't even know, is not concerned with organ donation at all. That's a separate team that needs to look after it. I have health issues, no one will want my organs. If I have a single health issue, my other organs are fine, why can't I be a donor? I am too old to be a donor? Absolutely not. Donation does not mean only the kidney, only the liver, only the heart. Donation means a number of things. So this myth also needs to be removed. Families of donor are charged for the cost of their loving ones' donations. Absolutely no cost. In fact, they are supported by the program as well as by the government if they make donations. Then this is a major issue still in India. Organ and tissue donation is against my religion. And well, rich and powerful people move to the front of the line when they need a transplant. Well, I will not address the issue, because this may actually be an issue which will require a different forum to be addressed, and our transparency in terms of our own self will help that. Only a transparent society can bring about a transformational change to produce a transparent system of organ allocation. There are certain other myths. What if one recovers from brain death? There is a myth. What if my patient recovers from brain death? That's not true. Nobody has ever recovered from a brain death. Then second, there are, this I've already discussed, I'll go to the next. There is another problem. I may be kidnapped if I register for voluntary organ donation. Well, there have been some instances where few incidents have been reported, but that should not prevent us from going ahead, for the simple reason that accidents on roads don't prevent us from driving. We still drive. So few of these accidents will occur, again because of human greed. Then another thing that goes on, and this is especially in the eastern part of the country, I will be born without the organs donated in the next birth. In fact, there are certain voluntary organizations which don't let organ donations occur in the eastern part of the country. We have to get them on board, because they will only help us to clarify this myth so that organ donations pick up there. As far as brainstem death is concerned, it is essential. I've already said it's absolutely essential for taking the organ transplantation forward, and the people who need to be on board are physicians, anesthetists, neurologists, neurosurgeons, and the trauma team. And this needs to be a continuous process. I think the hospitals which are already doing it must have established this process, but this process has to be ongoing, because new people join the medical profession, they have to be trained, they have to be made aware of this. So a brainstem death declaration team in every medical institution is a must. And to my mind, the basic requirement I have listed already. They should know their roles and responsibilities. They should be aware of the catchment areas, and they should be taking the rounds without fail twice a day in those catchment areas. They should be identifying potential donors confidentially. They should be regularly interacting with transplant coordinators and organizing training of resident and nursing staff in brainstem death certification on a continuous basis. And potential catchment areas include emergency and trauma area, wards catering to acute stroke, medical emergency, medicine, and neurology. It's not about only neurology. Still in our major hospital, it's internal medicine, which caters to most patients of acute stroke. Then intensive care units, all specialities. These are the areas should be frequented by the team. And as far as to increase organ retrievals, every medical facility dealing with emergency and trauma should be a potential retrieving center. You can imagine the numbers we have and how little retrievals are we doing. It's an estimate that there are about 1.5 to 2 lakhs deaths because of accident in the country. And the another estimate is we add about 1.5 to 2 lakh patients of renal failure every year. So if we can somehow match them, yes, we can increase the number of organ transplants. Coming to formatting guidelines for retrieval that I discussed previously, there is a lot of ambiguity and confusion about retrieval guidelines within the institution, because most of the institutions that I have interacted with in Delhi, that nobody is aware who is the person, who is the nodal person responsible in case an organ retrieval is required, leave aside having a team in place. Then it is important that as a first step, we have a clearly written SOPs for retrieval of organs that should be based on a guideline or a manual that is prepared by NOTO at the center. And organ retrieval is something which is actually limited by the time constraint. So the time is extremely important. From the time of certification of death and organ retrieval, that time is very well defined. The second step is development of a retrieval team led by a nodal officer who identifies the organs which can be harvested from a particular patient. Third step is to get in touch with the organ retrieval team, which may not be within the institution. We don't have enough people trained. So there may be a team which is outside the institution but within the city, which should be contacted. SOPs as far as transportation is concerned, the SOPs for transportation for individual ministries have been ready for the past 7 to 8 years. They have been ready for the past 7 to 8 years. Then where is the problem? The problem is in an age-old saying, practice makes perfect. There was a time, when ambulances, sirens were howling on the road and we still were in traffic jams, we would not let them pass. That has changed. Now the moment we hear an ambulance, we try to give way. So the same thing will occur. The more transplants we perform, we'll have no difficulty in having green corridors. So we are going to have discussions with various stakeholders in this under Niti Aayog, and we should be able to get through this as well. Developing an organ transplant manual, it's never too late. We have decided to have an organ transplant manual prepared at the center and circulated to every institution of the country. And here I invite voluntary participation from people who have already perfected this art, whether in the private sector or in the government sector. We would need help and we would need assistance to prepare this transplant manual, which clearly defines the responsibilities of every member of every transplant team, and also decide who all should be members of the various verticals that we propose to have in every institution in terms of a transport vertical, a retrieval vertical, and a transplant vertical. The manual should clearly define SOPs for brain stem death declaration, organ retrieval, organ transplantation as well. In fact, only 2 days back we had a meeting with the Ministry of Law regarding universal declaration of death as well. It's not an easy job because the law ministry, person from the law ministry is completely against changing the definition. So, but we'll look at an alternative which may even include, a separate act for it, a separate act in terms of how we can certify death, which also guides us regarding removal of emergency life care support systems, which is not as of now allowed under law. So organization, all levels of transplants under the organ transplantation program need 4 things. One is an organ vertical, one is a transport vertical, one is an IEC vertical, and a brain death vertical. So these 4 verticals have to be there in every place, every institution, every society to take the transplant forward. We all know these things. Now I'll deviate a little. Kidney disease is believed to affect 1 in every 10 Indians. There is no doubt. It may be more. 5 lakh Indians are believed to be in the need of treatment for dialysis. The number of deaths attributable to India is attributable to CKD is extremely high. And it's been said that low and middle income countries have the highest prevalence, have the highest people suffering from it. So what should I do? Looking at these figures, sitting at the directorate, what should I do? Should I increase transplant centers and number of transplants and be proud to be the world leader in terms of the number of transplants? Well, numbers don't really affect me because we are such a populous country. We'll beat anybody out in numbers sooner or later. So we'll have the highest number of transplants, there is no doubt. But can increasing the number of transplants get rid of the problem, the organ failure? So should I thoughtfully looking at reducing number of renal failures in India and pride in having reduced the need for dialysis and transplants? So these are the 2 contradictions, these are the 2 balancing acts which need to be done at the policy making level. So it could not be either of them. Now another slide I want everybody to have a look at is at the expense of the healthcare. Expensive, how much the US spends on healthcare and where are we in terms of spent on healthcare. And it's constantly said, and the government is criticized for not increasing the percentage of GDP in states of healthcare. Do we ever talk of lowering the budget of healthcare, lowering the cost of healthcare, or we talk of only increasing it? See, I am a doctor. I have to decide whose stakeholder I am. Am I a stakeholder for the healthcare industry, or am I a stakeholder for the patient? So healthcare today is, yes, a multi-billion-dollar industry that has profited even during the times when the share markets have dipped. The only industry which recovers the fastest is the healthcare industry. Even during COVID times, the amounts of stress the patients had, the healthcare industry was the fastest to recover in terms of the stock market. Expensive medical education has had a direct impact on affordable healthcare, there is no doubt. For professionals from such an ecosystem, it should not, but it has become a business like above, which is not good. So presently our budget spend is that pink triangle. The country is spending much more on the tertiary healthcare and seemingly very little on secondary, primary and the prevention. So we need to actually reverse this triangle for any program to be successful. Even Noto will achieve 100% results, the transplant program will achieve 100% results, and our outcome should be that we should not let any patient die of organ failures. So we reduce the numbers on the one hand and we increase the transplants on the other hand. That will produce a balancing effect on the amount you spent on the healthcare as well as achieving 100% success. So prevention of organ failures, are we ignoring prevention in quest of organ transplantation? The answer to this may be yes and no. However, I have my own doubts in terms of no. I would say yes, we are assisting organ failures. How are we doing it? Can we think of decreasing those numbers by 3 simple interventions? One that the government has undertaken, this present government has undertaken, of providing potable water to the remotest of areas in the country. Recently there was a report in newspaper where 36 out of 38 districts in Bihar have high level of heavy metal contamination in the groundwater. So we need to look at this aspect, which is resulting in renal failures. We never even try to know what is the actual cause of renal failures. We always put pointers to diabetes and hypertension. The factors are much beyond diabetes and hypertension. I have seen them as a physician. Then we need to stop indiscriminate prescription and usage of medicines, both allopathic and Ayurvedic. Our prescription should be guided by the patient needs. And last 20 years of my practice in medicine, I have just cut down the number of medicines a patient is taking. So similarly about liver, are we ignoring hepatotoxic agents? Again, alcohol is one, and indiscriminate and unnecessary use of medicines is another. Can't we eliminate chronic viral hepatitis completely by ensuring safe blood products and mass immunization? Can't we eliminate IV drug abuse as a cause of transmission of infections, including hepatitis B? This is an interesting observation, and this is not a figure that I have produced. This is from literature. Drugs cause 20% of community and hospital-acquired episodes of acute renal failure. And which acute renal failure would recover completely? Dr. Agarwal would be able to point much better than me. He is a nephrologist. So we must look at our prescriptions very carefully and see they don't harm the patient, because our Hippocrates oath says, first do no harm. Among older adults, incidence of drug-induced nephrotoxicity is almost to the tune of 70%. So prescriptions and somehow, CGH's prescriptions who are 70 and above, their number of medicines that they are taking is the highest. 12 medicines, 14 medicines. Do we ever look at how much do they need and how much is actually prescribed? Potentially, every drug is nephrotoxic unless proven otherwise. And this is true of the liver failure as well. Potentially, every drug that we use can cause hepatic failure. Even a single dose of rifampicin is enough to cause hepatic failure. A single dose of INH is enough to cause hepatic failure, from which the patient may not recover completely. So I leave you with some thoughts. The myth is organ transplantation is answer to the problem in increasing organ failure and increasing need for dialysis for kidney failure. I don't think so. Reality, only prevention of organ failures will provide answers and will provide a teeth to the program as well. Otherwise, we'll be happy in just increasing the numbers and say that I have done 6,000 transplants or I've done 5,000 transplants, but the ultimate effect on the society and the patient on a whole may not be visible. Take home message, let us simultaneously increase awareness of reasons of organ failure and need to donate organs. Strike a balance between need and greed. Need is about the need to prescribe. Do we need to prescribe the number of medicines that we are doing? Greed is all about a number of things. Every doctor needs to decide if he is a stakeholder for patients, material benefit or healthcare industry. Thank you. I don't have a thank you slide.
Thank you, sir, for enlightening the wide spectrum which need action before we really able to decrease the burden of endocrine disease. I will just open the house for...
Yeah, before I get a question, one thing. I am not at all against organ transplantation. My talk should not be perceived in that way. I am a big supporter of technology. However, I am a person who would say, let us use the technology optimally. Now, for example, I think a lot of people who are older to me here, there was a time when we used to remember 1,000 telephone numbers. Today that we have a mobile, we don't care to remember even one phone number. Similarly, we used to have so much knowledge in our brains. Today, everything is available on Google. So we don't care to remember because we think we'll have the information by Googling immediately. And at the same time, we do criticize Google patients who try to teach us medicine by studying everything on Google. Yes, please.
Thank you for that excellent presentation. I have two comments to make.
Yes.
One, I'm George Abraham from Chennai. One is in your prevention, I think that probably you missed that early detection of diabetes or glucose intolerance and hypertension in the community. Number two, the comment is that Dr. Sunil Shroff and we work together in the same hospital. And in major metropolitan cities, we can use drones to transport the organs rather than having the green corridor created. Dr. Shroff will make a comment on that because he was there when during the inauguration of the drone at Chennai by Honorable Minister Nitin Gadkari.
Yes, no, I did not miss on diabetes and hypertension. I deliberately missed it out. It was not an error, it was not an omission, it was deliberate. Because for years together, we've been told that Indians are prone to diabetes and hypertension. And we must detect hypertension and diabetes early to prevent organ failure. But have we gone into the fact why over the last 40 years Indians have become prone to diabetes and hypertension? Have we ever addressed this basic question? Well, this basic question is related to the fact that we have entered into an era of globalization. We have completely changed our food habits. We've completely changed our lifestyles. See, so that was a deliberate reason why I missed it. I am aware as a physician that hypertension and diabetes is a huge problem. I manage them day in and day out. I must have managed lakhs of patients of diabetes and hypertension. The second part I said, this drone thing, yes, the ministry is also looking at it on the possibility of using drones in other cities as well to avoid the green corridor. We are aware of it.
Dr. Shroff.
They are not obese, they develop diabetes. So it is not only the lifestyle, there are much more things involved in that, in the diabetes occurrence and in diabetic care.
You see, I'll never contest any statement that any colleague of mine makes. But if I go deeper into diabetes and hypertension, the problem of diabetes and hypertension started in India when we started using refined oils. There was a time when our own products were criticized and refined oils were promoted. And please remember, this lower socioeconomic status can only afford use of refined oils in the country. And these refined oils are responsible for a lot of metabolic disorders. So there are reasons much beyond genetics, reasons much beyond the lifestyle, which probably the medical fraternity has never cared to investigate for the simple reason because it's not money making.
Sir, excellent, very thoughtful provoking presentation has come from you, and I was very delighted to see how you have balanced both prevention along with increasing the number of transplants which you do. I have one request for you. I represent a society which has 1,700 members of transplant clinicians, not only from kidney, but liver, heart, lungs, and very passionate people, and we are growing very fast as well as a society. My request is that we should be, in fact, just before your presentation, I had done a presentation, and we are a 32-year-old society. It's about time that we are also a stakeholder in creating guidelines, in creating, the regulations on transplant and organ donation. And my request to you is, do consider us as part of this whole ecosystem and include us within the system so that we can, as a body, not as individuals, so that we can regularly contribute to the growth of transplant medicine. That's my request, sir.
That's absolutely essential. Actually, I said that in the very beginning, that we can't work in silos. The organizations which are already working in the private sector need to become intensely involved with this whole drive. And you please talk to our Dr. Anil Kumar, who is looking after NOTO in the directorate, and we have already taken the first step towards it. We'll be also registering voluntary organizations at our website, and we'll also need you to prepare the guidelines for that as well. You see, what happens is when we make guidelines, or for example, when we become administrators, sometimes, we have a biased approach towards making guidelines as well, that it may suit somebody, it may not suit somebody. So that being the first principle of administration, when we make those guidelines, we should be absolutely neutral. Yes, we would definitely invite your interest and will be delighted to have you on board.
I request Dr. Krishan Kumar for his comment.
Thank you very much, sir. And I can assure you that head of our family is standing there. Core of us are here with you. Our only mission is to build a team and move forward. I am a very big fan of that border film share. चमन में इखिलाते रंगो बूसे बात बनती है, हम ही हम हैं तो क्या हम हैं, तुम ही तुम हो तो क्या तुम हो. So please, we are ready, we are a team. It's a time, we have a leader. Even ministry is very keen, our Prime Minister is very keen. You all have worked very hard. Now it's the time to work hard and time to reap the fruits. We all are here to create a team, and we all are here with you. Let us move forward now. Thank you very much, sir.
Thank you.
Sir,
Thank
Indian
you.
Society of Organ Transplantation would work with you and NOTO office to increase access to the transplantations. Sir, we will take one photo, sir.
A group photo. Can I also request Dr. Sunil Shroff to also join in for the picture? If we... In the meanwhile, as they're taking the picture, I would like to take this opportunity to call the chairpersons on the dais for the next. Can I request Dr. Pratik Das to please join us, along with Dr. Himanshu Sharma and Dr. Narayan Prasad. Our speaker is Dr. Vijay Kher. Can I request Dr. Vijay sir to please also take the dais, check the presentation. Immediately after this, we're going to have lunch, but do not be mistaken, we shall be starting before time, that is 1:55 with a quiz. And then we're going to start with the talk at exactly 2 o'clock. So don't miss out. Be back after lunch to win some goodies and prizes at 1:55. And again, we're going to start the talk on time at 2 o'clock. Also, the oral presentations, which were supposed to be happening from 2 to 4, has been moved from 3 to 5. Please collect. Can we have Dr. Manish Balwani sir here for a picture? Over to the chairpersons and the speaker.
Good afternoon, everybody. I think we have a speaker on the dais, and Professor Vijay Kher does not need any introductions to this august gathering. But customarily, Professor Bijay Kher was the ex-professor and head of the department of Sanjay Gandhi Postgraduate Institute of Medical Science, Lucknow. Subsequently, he has established so many programs, nephrology programs in Delhi region. He was the chairman of Medanta. Now he has moved to his own institute, that is Epitome, Institute of Nephrology and Urology and Lions Hospital in New Delhi. So without wasting time, over to you, sir, to proceed with your presentations.
Good afternoon, and thanks, Narayan, for that kind introduction. I have actually changed the title of the talk to Osteoporosis in Chronic Kidney Disease, an underdiagnosed condition. And I'll tell you the reason why we feel that this is underdiagnosed. I'm not going to take coals to the castle because chronic kidney disease, mineral and bone disorder is so common in our patients that all nephrologists are highly aware of it. However, this is because of the alterations in the calcium, phosphorus, parathyroid, FGF23, which occurs in every patient of chronic kidney disease. There is declining GFR results in phosphorus retention, leading to multiple alterations in the calcium, phosphorus, vitamin D, and parathyroid organ as a system. And there is secondary hypoparathyroidism. There isn't a better trade-off that the body utilizes to produce a balance in the pathophysiological alterations which occur in patients of chronic kidney disease. So this background produces a lot of alterations in our body. The treatment of bone mineral disorders with calcium, vitamin D, and calcium receptor inhibitors and many other drugs result in many complications, the disease process itself as well as. So you have laboratory abnormalities, you have bone abnormalities which occur in these patients with, say, osteitis, fibrosa, adynamic bone disease, or mixed kind of mineral metabolic bone disease. And as a result of the disease process itself, or as a result of the vascular calcifications occur in these patients because of the treatment that we give to these patients. And these are not uncommon in our patients. You can look at the presence of valvular calcification in patients who have fairly high, 45% to 50% patients will have valvular calcifications. Coronary artery calcium deposition is not uncommon. Metastatic calcification is again fairly common, and when you have arterial calcifications, and that leads to an increased mortality, progressive increase in mortality as the calcifications go from medial to intimal calcifications, and you can see that the survival of these patients and sudden cardiac deaths are a common cause of death in patients of end-stage kidney disease. However, osteoporosis, which is usually not a central kind of a theme in the scheme of things that a nephrologist looks at, in fact is a common disorder, and that's what we will talk about in the next few minutes. Low bone mass with microarchitectural disruption that leads to fragility in the skeleton and predisposes patients to falls and fractures. So there is a high risk of fracture in patients with chronic kidney disease. This is not only related to the bone mineral disorder that is very common in patients of chronic kidney disease, but osteoporosis also on top of these bone mineral disorders, leading to high risk of fractures at spine, hip, pelvis, humerus, and wrist. However, diagnosis of osteoporosis in patients of chronic kidney disease becomes difficult because there are already a lot of the bone mineral changes and the architectural changes which this bone mineral disorder brings about. There is no doubt that our patients are now growing. I see more and more patients now in the dialysis units in the range of 50s and 60s and 70s. Transplant patients, yes, are still younger, but dialysis population is aging as well, and GFR changes occur in the population itself, fragility and fractures as we move along.
occur commonly in these patients. So low bone mineral density is not uncommon in patients with chronic kidney disease. So why are patients, what are the clinical risk factors for fractures? The reason why we are talking about osteoporosis in patients of chronic kidney disease is basically because it predisposes these patients to greater incidence of fractures, not only now but in future as well. And what are the risk factors in the common normal population? Advancing age, it's common in women post-menopausal. Previous fracture makes a person more prone to new fractures, glucocorticoid therapies, and many of our patients have had received glucocorticoid therapy, parental history of hip fracture. So if there is a family history in the parents that there has been a fracture, hip fracture, then there is a higher chance of that individual developing fractures in future. Low body weight, which is again not uncommon in our patients, current cigarette smoking, excessive alcohol consumption, and other causes of secondary osteoporosis like hypogonadism, which is again common in patients of chronic kidney disease, premature menopause, malabsorption, chronic liver disease, and inflammatory bowel disease. So let's look at some of the data that is existing from various parts of the world, and that's the overall prevalence of osteopenia and osteoporosis among patients of chronic kidney disease is not uncommon, as I said. Osteopenia in about 50% of patients and osteoporosis in about 1/4 of the patients. So 25% of patients will have, and why is it that you and I are interested in osteoporosis is this data actually which suggests that with increasing age and with increasing decline in kidney function, you can see that whether it is 45 to 65 years, both in women and men, or whether it is more than 65 years, women and men, you can see that the incidence of fractures, 3-year fracture risk, keeps on increasing as the GFR keeps on going down. And in fact, a person with more than 60 ml of GFR, you can see that there is either 2 to 4 times higher chances of developing fractures in patients of chronic kidney disease. So the incidence of fragility fractures in women beyond 65 years at 3 years was noted to be 4 to 9%. However, with graded decline in the GFR beyond 65, 1.25% across the GFR increase in the incidence of rise of fractures. So there is an exponential rise in fractures with decrease in glomerular filtration rate. And this is what is shown here, that patients who did not have CKD and those with the different colors that you see are ages between 40 to 50 years, 50 to 60 years, 60 to 70 years. And you can see that with increasing kidney dysfunction, you have higher chances of incidence of fractures in the middle age group, both whether it is men or women, you will have higher incidence of fractures in patients with declining GFR. Fractures are not only associated with the complications of fractures directly, but whether you have a history of coronary vascular disease or you don't have a history of coronary vascular disease, when you have fractures, you have an associated increasing possibility of increasing cardiovascular events or death due to cardiovascular mortality. So fractures probably predispose you to increase cardiovascular mortality in these patients. And if you look at whether patients of chronic kidney disease are at higher risk of complications when these fractures are being treated, and you can see that stage of chronic kidney disease was one of the important risk factors which was significant and with an HR ratio of 1.9, and stage of the chronic disease again was important as a risk factor for poor survival, and fractures and treating these fractures again turned out to be one of the risk factors in patients of chronic kidney disease. So patients who sustain hip fracture and those using dialysis have a higher risk of post-operative infections, revisions, readmissions, and a twofold increase in mortality in these patients. So that's the reason why you and I need to be worried about fractures in our patients.
And in patients of chronic kidney disease, why is there even a much higher risk of developing fractures is because of the alterations in the bone microarchitecture by the bone mineral disorders itself, changes in calcium and phosphorus, vitamin D deficiency, elevated FGF23, sarcopenia and frailty are not uncommon, and there was a talk earlier about the sarcopenia in patients of chronic kidney disease here. Glucocorticoid use, which I told you makes a patient more predisposed to fractures, is not uncommon in our patients. Hyperprolactinemia, secondary hyperparathyroidism, chronic acidosis and acid load, malnutrition, hypogonadism, inactivity. And one of the most important factors which many of us miss is the osteoporosis, which occurs at least in about osteopenia and osteoporosis in about 50% of our patients. So what are the changes which we find? If you look at the osteoitis fibrosa, the bone turnover, primary bone mineralization, osteoid tissue and bone mass, amongst the various disorders which are present in bone mineral disorders, osteoitis fibrosa, adynamic bone disease, osteomalacia, or mixed bone disease, which is what is common in our patients. And you can see that with osteoitis fibrosa, the bone turnover is increased. With adynamic bone disease, the bone turnover is low. Osteomalacia also is a low bone turnover disease. Mixed will have a mixed kind of features in these, and the various other mineralizations and osteoids and all have been shown here. And I'll not go over it again. I told you that these are the changes. So how do you assess fracture risk in a patient? Is usually a clinical determinant of FRAX score, and this is easily available on the mobile, and you can calculate the fracture risk in the next 10 years in your patients. And obviously another measure which is commonly used in the general population is the bone mineral density, which is the dual energy X-ray absorptiometry. For FRAX, whether presence of chronic kidney disease, there is no adjustment for eGFR. However, if you get an absolute risk of say 4, you make it to next level if you have a GFR between G3 to G5. So you will add one more. So the chances that this patient with chronic kidney disease will have a higher clinical score of future fracture risk on a FRAX score. The bone mineral density is something which was controversial. In 2009, bone mineral disease KDIGO guidelines, actually bone mineral density was supposed to be not used in patients of chronic kidney disease. However, 2017 guidelines at least have suggested, unfortunately, the guidelines on bone mineral density leaves a lot to be desired, and one cannot get good sort of clinical guidance from many of these guidelines. So, be as it may, in patients till the GFR is about more than 30 ml, you can continue to use bone mineral density as a marker for osteoporosis in patients of chronic kidney disease. However, in patients with a GFR less than 30 ml, bone mineral density may not provide you the same kind, because bone mineral disorders in patients below 30 ml of GFR is highly prevalent in these patients. So therefore, bone mineral density may be used in individual patients where the fracture risk is high and where you can use other markers which I will come. So we talked about the clinical risk factors for fracture, and I told you that in patients of chronic kidney disease, there are many of these risk factors which are present. We have advancing age of our patients. There may be many patients where we may not be taking this history, but they have had previous fractures. There is a parental history of fractures. Glucocorticoid use has been used in many of these patients. So you need to go back to look at the clinical fracture risk score based on these criteria. However, what we do not use in patients, especially in patients where we are not going to be able to use bone mineral, not going to be able to use BMD, is going to be using these bone turnover markers. So there are two types of bone turnover markers. One is resorption markers, and these are type 1 collagen degradation products, and many nephrologists and including me, I didn't know that many of these are easily available. And with a friend like Dr. Amrish Mittal, who has been the president of the Bone Mineral Society in India, he's been interested in this topic, and we've been working for many years together. And since bone biopsies are not commonly done in patients with bone mineral disease and chronic kidney disease, so we will have to use these markers which are available now in the market, and these can help you to find out whether patients have an high turnover bone disease or a low turnover bone disease. And that's when we can identify patients with osteoporosis and therefore be able to use appropriate therapies for these patients. So what are the resorption markers? C and N telopeptides, CTX, NTX, and these are available from the labs. You can use another marker which is called tartrate resistant acid phosphatase or TRAC5B, cathepsin and matrix metalloproteinase. So these are resorption markers. The bone formation markers are procollagen type 1 propeptides, C-terminal pickup as well as N-terminal PINP, osteocalcin, these are available, and bone isoform of alkaline phosphatase, which we do not use. See, unfortunately, PTH levels may not reflect always whether the patient is in a high turnover or a low turnover. Unless the values are below 100 or so, then you know that there is a low turnover bone disease. But values above 100 and up to about 900, one isn't very sure. The guidelines don't give you what is the, in a patient with CKD4 disease, what is the ideal level that you would want to maintain is anything between 3 to 5 times the normal values of PTS. So you do not characterize these patients by the difference in the PTH levels. However, fortunately, since BMD is not very useful in patients below 30 ml of GFR, there are newer methods which are being developed to find out or make a diagnosis of osteoporosis. And we are hopeful that these methods will become available soon and we will be able to use them in the clinic. Referral DEXA. DEXA uses the central bone system predominantly, but alterations in patients of chronic kidney disease may occur in the peripheral bones, not only in the cancellous bone, but also in the trabecular bones. So peripheral DEXA might help in those. Quantitative ultrasonography, quantitative computed tomography, high resolution peripheral quantitative tomography, high resolution MRIs, micro MRIs, radio frequency echographic multispectrometry and pulse echo ultrasonography. So there are newer methods which are being developed. How do you manage patients with osteoporosis? Prevent first fragility fracture or future fractures if one has already occurred. Stabilize or increase bone mass. Relieve symptoms of fractures or skeletal deformities. And try to improve mobility and functional status of your patients. So what are the therapeutic options available for us? Obviously, there are inhibitors of bone resorption which are available, and the bisphosphonates are very well known to you. The other newer drugs which are available is denosumab, which is now available as such. It was available as a drug, but now generic drugs are available. Calcitonin, estrogen, and selective estrogen receptors like SERMs or raloxifene, and stimulators of bone formation like parathyroid hormones or the parathyroid hormone-like drugs, and then vitamin D and the metabolites are already here. So these are the overview of the available therapies for osteoporosis and some alterations in their dosages with GFR. So what is known is that you are not able to use bisphosphonates. By and large, they've been contraindicated once the GFR is less than 30 ml or so. And majority of the patients that require treatment for osteoporosis may be in this range of GFR. So stage 4 and stage 5 kidney disease when bone mineral disease is also very common. So denosumab and romosozumab, these are two other newer drugs, monoclonal antibodies, which are available, and they may be used in some of our patients. What is denosumab? It's a fully human monoclonal antibody. It's an anti-resorptive
agent has high affinity for the and specificity for human rank ligand, which is receptor activator for nuclear factor kappa B, which is a master regulator of transcription factor actually. So it's not only in the bones but elsewhere in the body as well. And this is the osteoblasts and osteoclasts are formed from mesenchymal stem cells, and there is a signal transduction which occurs as the processes go, and rank actually is where osteoclasts the rank ligand binds with rank, and then the osteoclasts are so rank ligand monoclonal antibody doesn't allow the rank ligand to join or to join with rank, and therefore does not allow osteoclast formation, function, and survival. So the osteoclast formation is dependent on this rank ligand to rank sort of joining together, coming together and binding to each other. And that's how the osteoclast formation and function progresses. With this monoclonal antibody, the rank ligand is not able to join rank, and therefore osteoclast survival as well as osteoclast formation goes down. Bisphosphonates act at another enzyme which is actually through the mevalonate pathways. HMG-CoA changes to mevalonate, but its further course is brought about by FPPP synthase, which is inhibited by the bisphosphonates. And bisphosphonates get into the osteoclast and do not allow it to function. And that's how the bisphosphonates continue to remain, and then they get disengaged and they have to be excreted to the kidney, and therefore at a GFR less than 30 ml or so, you're not able to make it. So denosumab was studied in one of the largest studies, called FREEDOM study. You can't have data on denosumab without this study, and there was some patients with chronic kidney disease also in this patient, and it was seen that in patients with chronic kidney disease, you had increasing bone mineral density with the denosumab, and prevention of fractures occurred over 36 months. Then there was an extension study for another 5 years. So patients were followed up for overall 10 years in this study. And there is a 10-year safety data available in patients who were not having chronic kidney disease, and fairly good number of patients who had chronic kidney disease. And it was quite evident actually that you could see that the new vertebral fractures were brought down, non-vertebral fractures were brought down, and hip fractures were brought down with denosumab in the FREEDOM trial. And you can see that when you compare to placebo and you look at the annual incidence rate of new fractures in the FREEDOM trial, whether the trial, initial trial 1 to 3 years, and then the long-term extension arm for 8 to 10 years, and then the patients who were crossover, who had been in the placebo arm in the first 3 years, they got denosumab in the follow-up study, and you can find that actually, irrespective of the stages of chronic kidney disease, there was a significant decline in the fracture rates in these. So participants in every GFR subgroup showed a reduced incidence of fractures. And this is the data on the bone mineral density, and you can see that the bone mineral density grew all along, persistent with the gains in the bone mineral density. And this is one single dose study on pharmacokinetics of denosumab, suggesting that actually renal dysfunction does not make any alterations in the pharmacokinetics or pharmacodynamics of this molecule. So no alterations required in patients with kidney dysfunction. There is one major complication which occurs in these patients is hypocalcemia. So these patients must be initially treated with vitamin D. Their calcium must be monitored as well as maintained to start with, and then you should use denosumab in these patients. In patients with chronic kidney disease, it might take a month before you see hypocalcemia in these. So monitoring on a long-term basis is important. So this is in dialysis population where parathyroid hormones may be high, and you can see that with the use of denosumab, the parathyroid hormone levels also came down in 24 patients with severe hypoparathyroidism. And even when the levels of
more than 800 and they were low bone mass, they were treated with denosumab, and you can see that their IPTH decreased with denosumab and vitamin D administration. The high risk for hypocalcemia, you can see that these are, if you have bone alkaline phosphatase, it inversely correlates with the delta change in the calcium. The parathyroid hormone again inversely correlates. So patients who have higher PTH will have higher degrees of hypocalcemia. Those who have higher alkaline phosphatase will have lower levels of hypocalcemia in these patients. And you can see that the sensitivity and the baseline acid phosphatase again linearly inversely correlates with the delta change in the calcium. Can we use denosumab in patients with kidney transplant recipients? And although glucocorticoid induced bone density goes down very quickly in patients with chronic kidney disease and transplantation, so bisphosphonates are commonly used, or vitamin D supplements are used in these patients. But this is one study where people were given denosumab in these patients, and you can see that actually the denosumab therapy demonstrated a good bone efficacy and general safety in patients of kidney transplantation. So this is a safe drug to be used in patients with kidney transplantation, and you can see that the BMD improved in lumbar spine, femoral neck, and ultra distal radius as well. So there is an improvement in the bone density in patients of chronic. So how do you identify patients for wrist fracture? And so when you have patients in whom there is hyperparathyroidism, mineral bone disorder, acidosis, dietary restriction, which is not uncommon in our patients. We do a DEXA scan if the GFR is more than 30. Do a bone alkaline phosphatase. And I think as a nephrologist, I think if I'm able to sensitize you that we should be using these bone markers now in our diagnosis of bone mineral disorders in our patients, then it would be important. You will be able to identify patients where they can be offered newer therapies in these patients. So if your bone alkaline phosphatase is more than the median reference, so this is a high bone turnover disease. If it is low, then a low turnover bone disease. If it is a high bone turnover disease, then you would need anti-resorptive therapy. So if the GFR is more than yes, if the GFR is more than 30, then you could use bisphosphonates as first-line drugs, and those patients who do not want bisphosphonates or don't tolerate bisphosphonates, then you could use denosumab in these patients. However, in patients with GFR less than 30, you cannot use bisphosphonates, and in these patients, denosumab should be used in these patients. So this is the similar kind of a score. If you do a BMD and the BMD shows you that the either osteopenia is there or osteoporosis is there, you could use a bone alkaline phosphatase and then make a diagnosis of osteoporosis in these patients. What are the things that you need to get worried about when you are using denosumab? Calcium needs to be monitored in these patients, and prior to use of denosumab, ensure that you have vitamin D as well as calcium being given to these patients, and keep on monitoring this patient. This comes as an injection which has to be given every 6 months. However, also ensure that your patient is able to continue to take it beyond, because the moment you discontinue this therapy, you will have to give bisphosphonates, or otherwise this therapy must continue for a fairly reasonably long period of time, beyond 5 years or so.
Apologies, sir, but the time has actually run out. If you could.
That's the last slide. What are the other indications where you use? And Dr. Anand Kumar was sitting here for some time, and he said that men receiving androgen deprivation therapy for prostate cancer, women undergoing breast cancer therapy getting anastrozole inhibitors, bone metastasis, treatment of hypercalcemia, denosumab could be the drug where it can be used. However, since rank ligand and rank, this is a transcription factor which is present in immunological and all cells of the body, this would affect other areas of the body as well. So there would be a concern for infection and malignancy, although the FREEDOM trial, which was followed up for 10 years, there wasn't any concerns on these kind of things. Uh, Before I conclude, I think there is a survey form which has been distributed, and I would request you to complete the survey form before you leave this hall. Ladies and gentlemen, let me conclude. The diagnosis of osteoporosis and prevention of related fragility factors is complex in patients of chronic kidney disease, especially in advanced stages of chronic kidney disease. Denosumab is one of the few treatment options available to reduce bone turnover and maintain or increase bone mineral density in patients of chronic kidney disease, and has been shown to improve BMD in these patients, as well as may be useful in patients with kidney transplantation. The denosumab-induced hypocalcemia has been reported, and which disproportionately impacts those with ESKD. So therefore, this must be treated with vitamin D and calcium supplements. Choosing the right patient, and I think is most important, that individualizing therapies and choosing patients, giving patient-related outcome measures as the measure of outcomes in patients, I would think that you should individualize patients and then decide what kind of therapy should be given to each patient. Thank you very much for your patient hearing. So this is the survey form, and I would request that everybody fill this form. Thank you.
Thank you, sir, for your nice deliberation. We are running very much short of time, so maybe one question may be allowed from the audience.
Sir, very nice presentation. Only thing, denosumab post-transplant 1 year osteoporosis, there's no data about that. That is the one thing.
Yeah, there isn't data on denosumab, but denosumab, see, in post-transplant period, the corticosteroid induced is bone disorder is the one which occurs within the first year itself, and that's maximum, and therefore you need therapies for that. Now, whether at the moment most of us are using bisphosphonates, and denosumab could be an alternative treatment in many of these patients, but ensure that these patients are able to take denosumab for a longer period of time, because with withdrawal of denosumab, there may be a sudden bone resorption which might be increased, and they may get osteopenia, which is aggravated after discontinuation of. So at that point of time, one might have to use either bisphosphonates, or you will have to continue denosumab.
We can keep on the questions going, but if people want to move for lunch, that they can.
About this dialysis patients, you mentioned about stage CKD5 use of denosumab. So if we can take care of hypocalcemia, can we use it safely in dialysis?
Yes, yes. This is the drug for dialysis population. Phase 4, GFR less than 30 ml, bisphosphonates are contraindicated relatively. Yes. Although there are studies which have shown some usage in, but by and large the guidelines say don't use it. Denosumab you can use in all stages of chronic kidney.
If compared with teriparatide, then
teriparatide will be when the PTH levels are extremely low. In that situation, you are unlikely to use denosumab. Then you will have to use parathyroid hormone or the
in those
formats.
Situations we can use teriparatide, but up to what GFR we can use?
Teriparatide is actually contraindicated in GFR less than 30 ml. But I think there are papers which have suggested that you might have to use teriparatide in people who have adynamic bone disease or something.
We did references when orthopedicians asked us, and we usually say allow them to use it.
Yeah, there may be no alternatives in the patients where the PTH is extremely low, or there is adynamic bone disease, and then you will have to give parathyroid or teriparatide in these patients.
Thank you, everybody. Thank you, sir. And thank you, audience. Let's conclude the session.
Thank you so much. With that, we conclude this hall. I would also like to let everybody know that we shall be having the Durant machine perfusion demonstration in Hall C at 3 o'clock, which was supposed to happen in the morning, is going to be happening at 3 o'clock in Hall C, the Durant machine demonstration. Thank you so much. We're going to be starting with the post-lunch session at 1:55 in the next 25 minutes. Thank you.
session by Dr. Santosh Varghese. Is the professor and head of nephrology, CMC, Bangalore.
Was about a little more than that who got rabbit ATG. The primary
some usage in, but by and large the guidelines patients when these fractures are being treated, and you can see that
the attributable CKD is extremely high. And it's been said that low and middle income with emergency and trauma should be a potential retrieving. And somebody, it was a joke. One politician in a talk would encompass certain things where I would invite the interest of the private sector. And one thing that needs to be remembered is that we can't work in silos, not the private sector, not the government sector. And handshake requires two hands. If one hand comes forward, there could never be a handshake. So it has to be bilateral. Now, at the apex of the highest body that can offer or that offers technical advice to the Ministry of Health and Family Welfare, the directorate always is in a dilemma, and the dilemma is multifold. On the one hand, national organ transplant
by day 21 reaches about 7.5 milligram on day 21. So this has been our protocol. I apologize for the typo in the previous slide.